Great. I want to welcome commissioners and members of the public. This is a hybrid meeting of the Maryland Healthcare Commission. We have several commissioners here in room 100. The rest of the commissioners are participating by Zoom. The ground rules for a hybrid meeting continue to apply. I will begin with a roll call of commissioners. During the meeting, I ask the commissioners and presenters identify themselves before speaking to allow those watching online and those here in the room to have the same knowledge. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask commissioners and presenters to mute their electronic devices when they're not speaking. I'd also like to ask commissioners attending remotely to avoid putting substantive comments in the chat, as it can be difficult for those of us in the room to see the comments. MHCC posts documents that will be acted on or discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. Now call the roll. Commissioner Bhandari, welcome. I could see you on the screen there. Commissioner Blake. Commissioner Boyle, welcome. Commissioner Baczynski.
Here.
Welcome.
Thank you.
Commissioner Cheatham.
Here.
Welcome. Commissioner Douglas is absent. Commissioner Gilrude.
I'm here. I'm almost at the meeting, but I'm here remotely.
Thank you. Welcome. Commissioner Gilmore, I see you here in the room. Welcome. Commissioner Jensen.
Here.
Commissioner Agbabi-Aka.
I'm here.
I hope I pronounced that correctly.
It's like Bobby a cub, but that's fine.
I'll do my best.
No
Welcome.
problem.
Commissioner Spinner.
Here.
Welcome. Commissioner Stratton Duncan is absent. Commissioner Wang, I can see you on the monitor. Welcome. And Commissioner Wood is here. Welcome. We have one item on our consent agenda, the approval of the minutes from the September 19th, 2024 Commission public meeting. Does any commissioner wish to either remove that from the consent agenda or discuss it? Hearing none, is there any objection to adopting the consent agenda? All right, hearing no objection, the consent agenda is adopted. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Commissioner Boyle.
The pages 8 and 9, getting into Williamsport and Snow Hill in terms of change of ownership for nursing homes. And in each case, you know, it indicates that they would likely not, if they were going for a CON, likely not meet the qualifications. And it's kind of now up to OHCQ. I guess a couple of questions. I think it's still, does OHCQ still feel they don't have the authority to do anything about this? And how, what are the next steps that would give us? I know last meeting, you know, we voted on.
So I think that in these instances, OHCQ's approach has been to add conditions. I don't know specifically on the Snow Hill case if we've heard back from them on what they're doing. Jean Marie, do you want to come up here and respond to that? So we're still operating under the old regulatory regime until our new regs become effective. And at that point, based on the standards and criteria established, we could take stronger action than we do today, but those regs have not passed through the full review process. Until they do, we would be operating under the current regime.
Yeah, no, we actually with the Williamsport acquisition, we ended up getting a revision. So the real property and the fed rights went through, and then they have decided before they didn't get licensure yet, then they decided they were going to change things. So you're going to next month see a revised one. So the operator has not yet changed. So to answer your question, we haven't, you know, but to Ben's point, OHCQ is issuing licenses with conditions, and they've been doing this for about 6 months.
So I never used to. Okay. Thank you.
Great. Are there any other questions? Winnie Hawk has a new employee to introduce.
Good afternoon, Commissioners. I'm here to introduce a new staff person in my center. This is Vishal Mondle. He joined the commission in July of 2024. He is the first hire in a newly created position called Health Planning Health Planner and Financial Analyst. And he will primarily work within the center, but and also related programs. He'll work primarily within the CON division, but also other divisions within the center. And I think happily take on other projects as needed. Michelle comes to us from Johns Hopkins Health Plans. He, at that position, he worked as a senior project manager. He was responsible for financial and quality reporting of value-based care agreements for Priority Partners, which is a Medicaid managed care organization. And then prior to Hopkins, he was involved in large scale software and data development projects. Vishal holds a master's degree from healthcare management from Johns Hopkins Carey Business School. He is a certified professional in healthcare quality from NAHQ, and he has a bachelor's in electronics engineering from University of Mumbai in India. Vishal lives in Timonium with his wife and 7-year-old son, and please welcome him.
Bravo, welcome.
Thank you, everyone. Well, thanks for the introduction, Vinny. Mr. Chair, Commissioners, thank you for having me here. I'm enjoying my time with the Commission. Great colleagues and wonderful portfolio of work that I'm, handed over. So I look forward to contribution to the state and be in touch with all of you. Thank you.
Thank you, welcome. So Ben, do you have any updates not included in the written report?
So you'll notice today that we have a fairly ambitious schedule. I'm not going to say anything other than to recognize the work over the last month that the staff has taken on, as well as the work that some of the commissioners have generously given of their time to participate on. Particularly, I want to note the work that Dr. Brzezinski, Dr. Bandari, and Commissioner Wang did on the genetic screening. More to come on that. We'll look forward to sharing the results. And I did promise last month to send out a summary of all the reports that are due between now and the end of the year. I have that ready and I'm going to send that after the commission meeting today, but please feel free to ask questions if it's not clear what's going on and what's being done. Fortunately, today you're going to hear about, in addition to the work that's ongoing, we'll have 2 reports that are early completions for reports due for use during the legislative session in 2025. So we're making progress, more to come. Stay tuned, and naturally staff, as we move through today, we want the commissioners to have opportunities to answer questions, but we also want to recognize that we want to move through our agenda in a efficient and prudent manner. So thank you all. Thank you for your participation, and go from there.
Thank you. Agenda item number 3, certificate of ongoing performance application for PCI services for Johns Hopkins Bayview Medical Center. Eileen Fleck, Chief for Acute Care Policy and Planning, will present the staff report. Eileen, you have the floor.
Thank you. Good afternoon, Mr. Chair and Commissioners. I'll begin by reviewing compliance with key standards for the certificate of ongoing performance application. Next slide, please. On this slide, you have a summary of the standards that I'll be discussing. Next slide. As noted in this table, a hospital that provides emergency PCI services is expected to have those services available 24 hours a day, 7 days a week. From 2020 through 2023, the cardiac cath lab for Johns Hopkins Bayview Medical Center was almost always available. However, unlike other hospitals, it does not have a backup cardiac cath lab. That means that when routine maintenance is required or if equipment breaks down unexpectedly, then PCI services are not available at all. Patient care has been affected by the lack of the backup space over the past 4 years. there were 3 patients that were transferred to Johns Hopkins Hospital because because PCI was not available, and then also 1 was diverted before reaching the hospital to Johns Hopkins Hospital. For that reason, staff is recommending that a condition be placed on the hospital that will require the hospital to adhere to its backup plan, which involves stationing an ambulance and team at the hospital specifically for STEMI patients, as well as a team to handle those patients. The hospital would also be required to provide quarterly updates that will allow staff to monitor the downtime and the outcomes.
So we have some noise. If you could mute your phones. Mute your lines. Go ahead.
Between January 2019 and December 2023. However, in the vast majority of cases, the reasons were ones that were not within the control of the hospital, which is reflected in how the American College of Cardiology looks at door-to-balloon times. It removes those cases where the hospital did not have control over the delay for patient care. In the few instances when the hospital did have an opportunity for improvement, the hospital identified factors contributing to the delay and took action. Next slide. With respect to risk-adjusted mortality rates, the hospital performed similar to the national benchmark for both STEMI and non-STEMI patients for the 12-month reporting periods between January 2019 and December 2023. On this slide, we have the performance for STEMI patients. The hospital performed similar to the national average because in each reporting period, the confidence interval for the hospital's performance includes the national benchmark. If the confidence interval was entirely above the national benchmark, that would suggest its performance was statistically significantly worse. If the confidence interval was entirely below the national average, that would suggest it was statistically significantly better. But in this case, it is within the confidence interval, so it is similar to the national average in terms of its performance. Next slide. On this slide, we have the hospital's performance for 12-month periods for the non-STEMI cases. Again, the hospital in each reporting period is performing similar to the national average. Next slide. A PCI program is expected to achieve a volume this isn't lining up with my notes. PCI program is expected to achieve a volume of 200 cases or more annually. 200 cases is a target, not an absolute requirement. So this is the second box on the slide. And the hospital did not perform 200 cases. When we analyzed the CathPCI data, we found that in 2019, it fell slightly short. It was 197 cases. And then for the 2 most recent years, the volume was 141 cases in calendar 2022, and it was 131 cases in calendar 2023. We asked the hospital to explain what accounted for that steady decline in volume, and the hospital cited several reasons, which include the demographics of the population, the availability of resources such as cardiologists who facilitate referrals for PCI, the capacity of other hospitals to provide elective PCI services, and changes in PCI care based on contemporary research and evidence-based guidelines. Because this is a target, it's not an absolute requirement that the hospital perform 200 cases, and the hospital is performing similar to the national benchmark with respect to risk-adjusted mortality rates for PCI services. And the individual interventionalists are meeting the volume requirement of 50 cases annually over a 24-month period. Staff is recommending that the commission find the hospital meets the standard. Also in this table, in the first box, there's a requirement to demonstrate that the hospital is taking appropriate steps in response to concerns identified through its quality assurance process. We reviewed the information submitted by the hospital, including detailed meeting minutes and descriptions from the hospital of its activities, and we concluded that the hospital meets that standard. In addition to the overall target of 200 cases for PCI, there is a requirement that a hospital perform a certain number of primary PCI cases. The hospital needs to perform either 49 or 36 primary PCI cases annually. It's a lower standard if it's a rural hospital. In this case, the hospital is in an urban location, so the standard is 49. The hospital achieved that standard each year between calendar year 2019 and calendar year 2023, except in 2021, when the hospital performed only 44 primary PCI cases instead of the minimum of 49. The standard requires that a focused review be performed if the standard is not met. However, for both 2020 and 2021, staff waived many of the volume standards because of the COVID-19 pandemic. For this reason, staff is recommending that the commission find the hospital meets this standard and not perform a focused review. Next slide. As shown on in this table, there are requirements for external review of elective PCI cases. At least 5% of cases must be reviewed per program, and at least 3 per physician, or all cases if fewer than 3 were performed. The percentage of cases reviewed was well over 5% for this hospital, ranging from 29% to 49% for calendar year 2019 through calendar year 2022. There should have been 1 more case reviewed for 1 physician who had only 5 cases reviewed during a year instead of 6. Staff looked into this and concluded that this was an unintentional oversight by the external review organization. It was not something where the hospital failed to provide the information. And so we don't think that should negatively affect the staff's assessment of the program's compliance. There is also a requirement to review the performance of individual interventionalists. 10% of cases annually need to be reviewed. That can be completed through semi-annual reviews or more frequent reviews. The hospital met this standard through a combination of internal review and external review. The last standard described on this slide is regarding case review. Case review needs to occur at least every other month. The hospital provided documentation of case review meetings for calendar 2019 through calendar year 2023. The meetings included physicians, technicians, and nurses as required, and at least 12 meetings were held each year. Next slide. In addition to the case review meetings, hospitals are required to have meetings to review issues related to the system of care for primary PCI patients. Between January 2019 and December 2023, the hospital held at least 11 meetings each year, except in 2019 when only 9 meetings were held. Generally, staff considers holding 10 or 11 meetings each year as acceptable. Because sufficient meetings have been held, though, for the 4 most recent years, staff recommends the commission find the hospital complies with this standard without a condition for reporting. For elective PCI cases, in order to verify that PCI is being performed only on appropriate patients, there's a requirement for external review of elective PCI cases to evaluate appropriateness. The hospital performed these external reviews from January 2019 through June of 2022. We were able to review those reports. There was only 1 elective PCI case that was deemed rarely appropriate by 2 or more criteria. Staff requested additional information on the follow-up for that case and were satisfied with the response from the hospital. For primary PCI cases, primary PCI should only be provided to suitable patients. We analyzed the cath PCI data and noted that between calendar year 2019 and calendar year 2023, there was only 1 patient who received thrombolytic therapy. The number of patients that the hospital reported who received thrombolytic therapy was 2 patients, which is still below the threshold for this standard. That concludes my overview of staff's analysis. Next slide. Staff is recommending that the commission issue a certificate of ongoing performance that permits Johns Hopkins Bayview Medical Center to continue providing primary and elective percutaneous coronary intervention services for 4 years with the following condition. It's a very long condition. Johns Hopkins Bayview Medical Center must adhere to its backup plan when the cardiac cath lab has planned downtime or is unexpectedly down, which includes having an ambulance and team stationed on site specifically for transport of STEMI patients. The hospital shall report at least quarterly on the amount of downtime for the cardiac cath lab, including the dates of downtime with start and end times, any instances in which STEMI patients were transported to another hospital due to downtime of the cardiac cath lab, the amount of downtime taken for patient transport to another hospital, and the time taken for the ambulance arrival if an ambulance was not already stationed at the hospital for STEMI patients due to unexpected downtime. This information shall be reported within 30 days of the end of each quarter of the calendar year, beginning with the fourth quarter of 2024 and continuing at least 8 quarters until staff releases Johns Hopkins Bayview Medical Center from the condition. Before ending my presentation, I want to note that there are some representatives for Johns Hopkins Bayview Medical Center attending remotely who are available to answer questions. Those are Dr. Jeff Trost, Medical Director, Randy Kaminsky, Administrator of Medicine, and Deborah Frankowiak, Cardiology Data Coordinator.
Thank you, Ellie. So what I might do is maybe we'll put a motion on the floor and then have discussion, if that's okay. So do I have a motion to approve the certificate of ongoing performance application for PCI services for Johns Hopkins Bayview Medical Center?
Motion.
Thank you, Commissioner Brzezinski. Is there a second? Commissioner Boyle, thank you. Any questions? Commissioner Jensen?
Yes. Back to the volume target of 200, and they were in the, significantly below that in the last year. Is there a level of volume that would suggest that independent of mortality rates, you'd say that's not enough?
I think that's something we should consider defining in our regulations. We don't have something defined, and so I think it's hard to say. I wouldn't be comfortable making a statement about that without having the backing of their staff, other input of experts on that at this time. So it's something we're aware of, I would say, and there are other issues where we think maybe we should look at our regulations and make some small changes.
Seems that would be a good thing to look at because it's sort of the difference between forward looking and backward looking, right? If volumes go down, the data would suggest that eventually there's going to be a problem. So you could wait for that and hope that the other factors prevent it, or you could do forward looking if it's below a certain level. But that's a pretty significant drop below the target.
It is. I mean, I do think because the hospital is performing acceptably in terms of its risk-adjusted mortality rate, and because the individual physicians are doing the volume that we associate with good quality, that those are factors, as I wrote in the report, that should be considered. But I think it is helpful and something we'll definitely think about.
And I don't know, this might be a question or just a way to think about it. I imagine that the technological environment, as it advances, the threshold between the volume that is unsafe and the level of volume that would be moving lower. That with better technology, you could get better outcomes, even though you're processing fewer patients. Is that a reasonable, is it abstract, but in the abstract, is that sort of a reasonable way of looking at it?
Well, I mean, I think also part of the rationale is that it's harder to know if a program is good if it goes too low, right? I mean, the confidence interval becomes very large. And so the performance would have to be very, very bad in order for it to show up if you're relying on the performance measures as we do. And so I think that is a consideration. I mean, I don't think, with cardiac surgery, we say if it's below 100 cases, right? And so maybe there's a reason to think below 100 is too low for PCI. But yeah, part of it is being able to rely on performance measures. When the volume gets too low, it becomes hard to know if it's good. And sometimes it is doing fine. And that's why you do the focused review.
Sometimes they've just been lucky.
For me, practicing in hospital environments, part of it is the process, the personnel process. You have personnel turnover. There needs to be a sufficient volume to maintain that, institutional memory of how to do this right and how to do it well. And I see that in our small hospital, some of these things that are important and we need to do, but we don't do them very often. It's almost like recreating it every time you do it. So, for proficiency, for reproducibility, reliability, it seems like volume standard has merit. I have a follow, this is a separate question. For the times when there was no cath lab available, what was expected of the hospital at that time? Not what's in your condition now, but over the last 4 or 5 years, what were they supposed to do when that cath lab was down?
Well, they notify MIMS, and so they've given us copies of email messages to MIMS saying, okay, we have downtime, you should divert patients if you can. They notify them as soon as they're aware of that, and so that is what they should do, so that patients can be diverted when they don't have services.
So in these past 5 years, they did what they were supposed to do when their cath lab was down.
Yes, and then, I mean, they should do what's in the best interest of the patient, which would be trying to transport them if they think that's best, or providing thrombolytic therapy if that just seems like the better option in terms of timing. So there are those expectations.
But did we have any findings that they didn't do what was in the best interest of the patient in those 4 cases?
No, I mean, they are transporting patients, right? So I'm not saying we need to do a focused review, but I'm saying we should have a condition and pay close attention.
Okay, my pushback on that is we set an expectation of the hospital to notify MIMS and treat the patient to the best standard of care possible, whether that's transfer or thrombolytic therapy. From what I'm hearing, they did do that, but even though they did what we expected of them, we're still requiring an additional condition on there. And is this I imagine they're not the only facility where they've had a cath lab down or where they weren't able to do PCI for a period of time. To me, this almost seems like we're talking on both sides of our mouth. We're being inconsistent. We say, oh, this is what we want you to do. You did what we asked you to do. But I don't think we asked you to do enough, so we're going to put additional conditions on there. So I'm giving some pushback as to why do we have to put on these additional conditions if the facility is operating in the manner that standard we held them to prior to this.
So we expect 24/7 availability. Obviously, like that's a high bar if we truly mean 24/7. They don't have the backup space, right? So other hospitals, if they have a lab go down or an equipment go down in one, then they have something that they can turn to. So they have a better, like a more robust backup system. And with this, they don't have, that other space, whether it's another cardiac cath lab or an operating room that can be used. And it does seem like there's been more patients affected, right? More downtime where you can't provide it all together compared to other hospitals, because when you have the backup, right, it's okay if you don't have it for one room, you can provide the service in another room. So I think we did see it as they are different from other hospitals in their ability to provide closer to 24/7 PCI services.
The condition, is it requiring, because the first sentence is that they have to follow their backup plan. Are we imposing anything in that backup plan that they didn't?
The backup plan is one that they told me was their backup plan or would be their backup plan, which I accepted. So I did not come up with new ideas on a backup plan. It is.
Backup plan is like a corrective action based on our findings over the last 5 years.
No, I think it would be best to ask them that question, because I think it would be best to ask them, because to some extent, like I said, like if they know they're down, they notify MIMS and then try to make sure the patients are diverted. You can have people that walk in the door still, in which case you need to decide, should we transfer them to another hospital? And so they have transferred them to other hospitals, and that, would require having calling the ambulance. I think in terms of the timing of that over this period and the plan that they've been using, I would ask them.
Just a point of clarification, so the commissioners understand that they're operating with one cath lab on an ongoing basis now. Just to be sure everyone understands that the typical process is to have at least 2. I think the question for them is, when's the second cath lab going to be open? Because I think it's essential at some point that second cath lab open. I know that there's issues right now. I think that's part of the questions that if we're going to ask them to come answer these, they should also give us additional clarity on when that second lab will be back in operation.
So they
How
did,
long's it been down?
What was your question?
How long has the cath lab, the second cath lab been closed?
So they haven't had a second, it was actually like an electrophysiology lab, right? So I think it was seen as backup space even before 2020, and from 2020 onward, they've just had one space, one cardiac cath lab without the backup space.
Is there a plan to have a,
So I've been told that they are,
they're online, right? I mean,
Yeah,
Yes,
I'm here. This is Jeff Trost. I'm happy to answer that question if you'd like.
Yes, go ahead.
So thank you for having us. Thank you for considering. So yes, we are in very high level discussions at the highest level involving our president all the way down to discuss this issue. We are planning to have some sort of backup space. That's going to take time and an investment in a lot of people resources and obviously financial resources. Right now, we're considering two options, either refurbishing the lab that Eileen had mentioned. We until 2020, we had two labs, one of which was an electrophysiology lab that was decommissioned because of a lack of electrophysiology, a lack of EP volume. That's one option. Another option is to refurbish an existing interventional radiology suite to be functional as a backup cath lab in the case of downtime. We anticipate that the ability, first of all, we have to identify obviously the financial resources that we're going to need to do that. Our leadership is committed to basically pursuing one of those two options. We also have to basically figure out a lot of logistics related to both of those options in terms of what would be feasible in the event that we would need that backup space. So there are a lot of details to be worked out. We anticipate that we will have some sort of backup space up and running within a year to 18 months at this time. And that's what we've communicated to MIMS, by the way. Everything that I've said has been communicated to MIMS. We've engaged MIMS as well because they've raised a similar concern. So I hope that answers your question.
I have a question. Commissioner Bazinski here. We're talking about requiring the addition of another cath lab in the context of declining patient volumes. Is your patient volume declining because you only have one cath lab, or are there other causes to your patient decline? And if it's anticipated to continue declining, where you'll never get close to that 200 level, should we even continue this program here at this facility?
Yeah, thank you for that question. So our volume is not declining because we have one lab. We believe that our volume basically has been impacted by several things, including certainly the demographics of our population, the initiation of an elective program basically close by from another hospital has certainly not helped. And I think the volume decline is a little deceiving because as Eileen alluded to, but really didn't give any detail about, common practice now, I've been doing this for 19 years. It used to be that we, in the cath lab, we looked at basically the angiograms and we basically eyeballed what we thought was a blockage and basically made a decision to stent or not stent based on that. And that was a very kind of rough assessment. We now do something basically without getting too much into the weeds. We do basically something called fractional flow reserve, which is a stress test on the table to look at patients who have kind of borderline blockages in the lab. We put wires down the coronary arteries, but that doesn't count as a PCI. Basically it doesn't count towards our volume, but what it does is it actually, in many instances, we are dissuaded from putting stents, whereas maybe 10 or 15 years ago, we would have put a stent in. So what I want to tell you is that I think certainly a good portion of the volume decline that we've had is due to the fact that we're intending to basically figure out whether we should be putting stents in appropriately, and we're using relatively new technology how to do that. So, I want to underscore to the commissioners that that's certainly part of our volume decline, is wanting to do the right thing. As all the commissioners know, the flip side of having a volume requirement is it unfortunately can incentivize interventional cardiologist to do the wrong thing. And that's not what we want to do. So I hope that answered your question. I believe that we also have other plan in place. We're certainly conscious of the volume issue, and we have plans in place to try to grow our program by hiring more cardiologists to see more patients, to decrease downtimes, to provide basically more access to care at Bayview. So we believe that our lab is still capable of growth.
So I guess to reflect on that, so I get it correct, you're still doing many coronary interventions, but you're not placing as many stents, you're not doing as many angioplasties, but you're still catheterizing high numbers of patients. The standard of care and the technology has advanced since this standard of 200 PCIs per year was established. So perhaps that number of 200 needs to be looked at again if the standard of care is changing. I've been in medical practice for 20 years, and I agree. I've seen a lot fewer stents and angioplasties over the last few years than the first few years of my career. So there is a evolution in technology. So
I agree with everything you've said.
okay, maybe this does take. We should be looking at these number standards again.
That all makes sense. That's very, very helpful information. I would, Commissioner Jensen, I would feel more comfortable if we had some more data to support. How are we going to close this gap? I mean, right now, we have a target of 200 and we're at 136. And that doesn't make me particularly comfortable. I'm not sure what the right answer is, right? Is it to move the target down or to try to get programs either out or up? But this conversation suggests that disconnect is only going to get broader, and we should take a hard look at that. Is that 200? Is that in a COMAR reg?
Yes, it's a target though, so this is not an absolute requirement, and it's partly, yes, it is.
So that's my point is.
But it's written in the reg as target.
Yes.
Right, but that's what I'm getting at. So that to change the 200 number would be harder than to put in place some process that we would use internally to how we would analyze these differences.
Give us assurance that despite not hitting a target number that's
Right.
years old, we're still meeting the standard care.
Right. And to ensure that we're doing it consistently across applications. So it's not just staff looked at it and said, we're comfortable with it this time. The staff looked at it, applied some agreed upon analysis that's going to be applied in every case and feel like we're okay. That's what I was getting at.
Probably look at this closely at some point.
I take it, Commissioners, you're not concerned though with this application, just come
No.
back to the, okay, I didn't think so.
Not after the explanation.
Chairman.
Yes, go ahead.
Ben Steffen. I had one more question. It was, I was curious about the quote unquote changing demographics, given the ample evidence that cardiovascular disease is extremely common and frequently undiagnosed in the African-American population. What steps are you taking, recognizing your geographic positioning? What are you doing to reach out to the population? Obviously, when you're talking about emergency PCIs, that's too late, but are you really engaging the community in preventive cardiac services that might alleviate down the road the need for an emergency PCI or an elective PCI or anything you're doing? Keep in mind that in Suburban, when their cardiac surgery application was approved in 2006, they came forward with a pretty ambitious program to reach out to the population in Prince George's County to raise awareness on cardiac services that might be available. And I wondered if you had a chance to talk to any of your colleagues in Bethesda about those initiatives and whether they'd be appropriate at Bayview. Perhaps you're already doing that, but I thought it was a little unusual to say the demographics are changing. I understand that statins and other early interventions may be decreasing the needs, changes protocol, et cetera. But wish you could comment on that because I think you might be missing an opportunity.
So Mr. Steffen, thank you for that comment. And that certainly we take that to heart. I think Bayview has been extremely active in the community with outreach. I know the cardiology division from time to time conducts health fairs, health screenings for cardiovascular health. And those are very well attended. Many of our faculty participate in them. And that certainly can be a source of I don't want to say clients, that doesn't quite make sense, but certainly folks who might be able to benefit obviously from all aspects of in the spectrum of cardiovascular care. I would remind you that we are the last kind of I guess the last stop in cardiovascular disease. The most important part, I would love to be put out of business as an interventional cardiologist. I think prevention is the most important part of what we do. And again, certainly that's something that we've been doing at Bayview for decades now. Short of that, I'd be happy to take your suggestion. We have certainly our friends at Hopkins and Suburban Hospital, and I certainly will plan to reach out to them as well.
Thank you.
I have one short question. Commissioner Bazinski again. You mentioned getting another cath lab space back online. You mentioned that you decommissioned an electrophysiology lab. Do you need a certificate of need to add an additional PCI services? Eileen is saying no.
No, anyone can build a cardiac cath lab without our permission. In terms of hospital, yeah.
Building one right now.
To your basement. That was a game room. Okay.
Are there any other commissioners with questions or discussion? Yeah. I'll call the motion. All in favor of the motion to grant the certificate? Say aye. Aye. Are there any opposed? Motion passes. Thank you, Eileen.
Thanks.
Agenda item number 5. In 2023, the Maryland legislature passed legislation that established the Behavioral Health Workforce Investment Fund. The legislation required the Maryland Healthcare Commission.
Four, I think we're at 4.
4.
You're right. I apologize. Thank you for the correction. The General Assembly, agenda item number 4, has proposed amendments to COMAR 102507, certification of electronic health networks, medical care, electronic claims clearinghouses, and COMAR 102518, health information. General Assembly passed 3 pieces of legislation in 2021 and 2022 requiring MHCC to adopt regulations to support the implementation of a consumer consent management application and health data utility by the state designated health information exchange. The legislation also includes reporting requirements for dispensers and electronic health networks. Nikki Majewski, Chief of Health Information Technology, will present proposed amendments to COMAR 102407 and COMAR 102518. Nikki, you have the floor.
Thank you and good afternoon, Commissioners. You may recall the same regulatory frameworks the Chair just mentioned were recently amended and finalized this past May to support the implementation of House Bill 812, which was passed by the General Assembly in 2023. That is the legislation that prohibits electronic health networks and health information exchanges operating in the state from disclosing legally protected health information. Amendments to the draft regulations being presented today are new and support legislation passed by the General Assembly in 2021 and 2022. Stakeholders have been engaged in discussion of the potential amendments since 2022. And these amendments had to be put on hold last fall to develop emergency regulations to support implementation of House Bill 812. Staff appreciates the nearly 90 stakeholders that over the last 18 months helped in various ways to shape the proposed amendments that I'm about to present. Next slide. The next 2 slides overview the 3 bills passed during the 2021 and 2022 sessions. These bills aim to advance use of health IT statewide with provisions to expand the role of the state designated HIE CRISP through clinical and public health reporting. The legislation also strengthens consumer control around sharing the personal health information. with a centralized consent management application that would be developed and maintained by CRISP that would allow a person to opt out from having their information shared or disclosed by HIEs operating in the state. Next slide. The legislation also establishes a health data utility operated by CRISP and requires dispensers to submit information on non-controlled prescription drug dispenses to support treatment and care coordination and other public health interventions. Next slide. COMAR 102507 and 102518 are the existing regulatory frameworks to support requirements for EHNs to report electronic healthcare transactions to CRISP, dispenser reporting of non-controlled prescription drugs to CRISP, the implementation of the consumer consent management application, and the operation and maintenance of a health data utility. Staff has sought additional stakeholder feedback and in May, and also convened 3 virtual working sessions over the summer to discuss the draft amendments. Next slide. 8 organizations submitted a total of 77 comments with several recurring themes across commenters. Some comments included technical questions related to HIE's integration with the consent management application, and other comments requested clarifications related to reporting protocols, timelines, and uses of certain data. Next slide. I will now overview the amendments to COMAR 102518. Next slide. So the amendments specific to the consent management application include a new definition defining consent management application and clarifying the term opt-out. It also includes the required components for the consent management application and the implementation timeline, the requirements on HIEs as it relates to connecting to the consent management application and making information about it available to the public, and requirements for CRISP to provide notice if the consent management application is not operational when service resumes.
Sorry to interrupt you. I have a question about the consent management application. And is that a quantize either, yes, you can share my information, or no, you can't? Or is it you can share parts of my information, but not other parts of my information? What are we asking, what's legislature asking of our vendors in this?
So initially it will be an all in or all out. And the goal would be to enable more granular control over time. But initially, just to get it out there, it would.
So this legislation is looking for a electronic way of healthcare consumers to opt in or opt out of health information exchanging.
Yes, and there's currently 17 registered HIEs, so this would allow the consumers to go to one source and opt out, and all those HIEs would have to use this application as opposed to right now where they'd have to go to each HIE individually and submit an opt-out.
13 HIEs in Maryland or in the nation?
Operating in Maryland, some of which include many EHR vendors.
Okay, thank you.
And then the last thing I was going to notice, there's some compliance exceptions for the consent management application. The next slide, please. As it relates to the dispenser reporting of non-controlled prescription drugs, the amendments include adding dispensers to the scope of Chapter 18 and new definitions for dispense, dispenser, and non-controlled prescription drugs. Also included are requirements for dispensers to report dispense information to CRISP and requirements for MHCC to develop a data submission manual for dispensers, which would include certain information such as frequency of reporting and technical specifications, as well as processes to request public comments on the manual and obtain commission approval. There's also protocols for CRISP to accept and disclose dispense information, and a process for dispensers to request a waiver from reporting. Yeah.
For clarification, a dispenser is not a pharmacy, so to speak. Currently, pharmacies do this activity of reporting non-controlled prescription drugs to a health information exchange, correct?
So they would have to they would be required to report to CRISP this information.
Do pharmacies currently have to do that?
No, they don't, well,
Well, for certain controlled,
Or not
for
control.
control to the Maryland, this would basically include everything now. So for what they're already mandated to report to the Maryland Prescription Drug Monitoring Program as it relates to controlled dangerous substances, this would all be the non-CDS stuff.
Okay, thank you.
Oh, and yes, next slide, please.
Quick clarification, this is Commissioner Bobbica. So they would be reporting all the medications patients are on now?
Anything defined as a non-controlled a non-controlled prescription drug. Any controlled dangerous substance would still be reported to CRISP through to the PDMP essentially, but there will be a process to streamline, so they're not submitting two, they can submit everything, and it would be sort of parsed out.
Basically, if a provider could look at CRISP and get controlled substances and then non-controlled substances.
Right.
That the
Oh.
patient has
Way better.
passed. Right.
Amen.
Yes, will complete.
Yep.
Okay, and then on this last slide here, as it relates to the health data utility, the amendments include a new definition for health data utility, improvement of patient safety, and state health improvement program. Includes requirements for CRIS to operate the health data utility and be designated as a reporting entity to the Maryland Medical Care Database. And it includes protocols for CRIS for disclosing information and collaborating with certain state agencies on the data uses, and requirements for CRISP to establish a consumer advisory council that includes certain representation and adheres to the Maryland Open Meetings Act. Next slide. So now I will overview the proposed amendments to Chapter 7. One more slide, please. So these amendments are specific to EHN reporting of electronic healthcare transactions. New definitions are included for improvement of patient safety, mitigation of a public health emergency, state designated HIE and state health improvement program. Requirements also for MHCC certified EHNs to submit certain data to CRISP for clinical and public health purposes and the data submission schedule, and requirements for CRISP to develop and publish technical submission guidance for EHNs. And there's also processes for EHNs to request a 1-year reporting exemption. Next slide. That concludes my presentation on the proposed amendments. This slide highlights the anticipated timeline to finalize the regulations. If adopted today by the commission, the proposed amendments are expected to be published in the December issue of the Maryland Register with a 30-day public comment period. And we would bring final regulations back to you all in February with an anticipated final effective date of March 17th. Next slide. At this time, commissioners, we ask the commission adopt COMAR 1025-07 and COMAR 1025-18 as proposed regulations.
you start the discussion, the motion.
So
I'll second.
Thank you. I'll read the motion just to make sure we're all on the same page. That was, I'll interpret that as a motion to adopt the proposed amendments to COMAR 1025-07 and 25-18. Are there two? Is this written as two motions? Okay. Why don't we, I'll rephrase that. We'll just do it again. We're going to, how we do a combined motion to approve the proposed amendments to 1025-07 and to 1025-18. Whole package in front of it, single motion.
So moved.
Second.
Very good. So, any questions, discussion?
You have a question?
Go ahead, Commissioner.
Thank you. Currently in the EHR that we use, Athena, the non-controlled substances are reported in the patient's chart. So there exists something that brings them in there. So I'm concerned that this may be redundant or somehow duplicative of what technology already exists. And I don't expect an answer on that or whatnot, but I just wanted to bring to your attention that it may be new for CRISP to see this data, but this data is currently being exchanged in some way from some sort of pharmacy benefits clearinghouses or something to the EHRs. So please don't give us duplicate copies of everything in the chart. Thank you.
Oh,
If
I have a question.
Oh.
Go ahead, please, Commissioner.
I think that that's because some EHRs have SureScripts, and SureScripts is what's providing that information. But not everyone's EHR or e-prescription has SureScripts to get non-controlled substance medications.
Thank you
Yeah.
for that.
Yeah, because yeah, but I realized that if you have SureScripts embedded into your EHR, because it has e-prescribing, it will show all the all non-controlled. But I don't think every EHR has SureScripts, or every e-prescription has SureScripts. So therefore, there are individuals that don't see that information at all.
Thank you.
So for you and I that have like Athena or using Athena, it will be a duplicate if we decide to go seek the information on PDMP. But it's kind of, our PDMP is embedded in Athena as well as SureScript. So we already have all that data. But if you're not using that sort of EHR, you don't have that data.
Question about the consent management application. At this point, we're really managing just opt-outs from the whole process, right? As opposed to individualized opt-outs, particular kinds of information.
So yes, this would be a general opt-out. I mean, there'd still be other, requirements like for legally protected health information as it is to opt into sharing that to a specific treating provider.
But I think it's important to emphasize that the gain here is that the common consent application would apply. You could, today, if you want to opt out of CRISP, you go to the CRISP website and opt out. But that doesn't mean that you're opted out of Epic, which is a well-known EHR vendor, but also has a HIE functionality. If you wanted to opt out of Epic, you would go to Epic and opt out. And you wanted to, I actually have records at Sinai. They use Oracle. I better opt out. So the efficiency is that if a patient really committed to wanting information opted out, they can, through one opt-out mechanism, eliminate information sharing throughout the entire universe, or conversely, select those that they don't want to opt out from currently. The gold standard or the vision is that this would be granular, but going through this over the last couple of years, I think we've made some progress, but the vendors say they need more time to implement granular consent, which, clearly is going to be the most beneficial to patients.
Thank you. Are there any other questions or comments? All right, I'll call for a vote. All in favor of the motion?
Aye.
Aye.
Are there any opposed? Carries. Thank you, Nikki. Now we can jump ahead to agenda item number 5. In 2023, the Maryland legislature passed legislation that established the Behavioral Health Workforce Investment Fund. The legislation required the Maryland Healthcare Commission to do a behavioral health workforce needs assessment study and recommend an initial allocation of the funds and identify specifically which programs the allocation will support and the number of professionals and paraprofessionals the allocation will train, certify, recruit, and place. The legislation did not specify an amount for the investment fund, but instead relies on our assessment and other information to set the funding source and level. Behavioral health workforce needs assessment is complete. You have a copy of the finalized report. Trailhead Strategies, a workforce and economic development consulting firm, consulted the behavioral health workforce assessment study. Mr. Andrew Hall, President and CEO of Trailhead Strategies, is here to present us with the findings and recommendations in the report. Andy, you have the floor.
Thank you, Mr. Chair, and hello, Commissioners. How's my audio? Can everyone hear me?
Yes.
All right, thank you. I'm also going to share my screen. And it says that it's gonna stop someone else sharing. I'm just gonna confirm that's okay and press yes. And then we'll be off and running. So while that's pulling up, I know you all have, can everyone see my screen both on Zoom and in the room?
Yes.
All right, perfect. And so what I'm hoping to do right now is to spend about 15 or so minutes hitting the high notes of the report. I know I've been here once and shared a little bit about our progress in our methodology. So I'm going to focus more of the conversation today on just kind of the major takeaways and what it might mean for the state of Maryland. So again, my goal will be to run through a few slides in about 15 to 20 minutes, and then leave the rest of the time for discussion. So does that sound good to Tracy and Ben, to the team, or did you want to give any opening remarks?
Go ahead, Andy.
All right, let's do it. So we started this work really in earnest in January of this year, and we kind of fundamentally had two questions. What is the extent of the shortage, and how can the fund help? And so what did we do to try to answer those questions over the last 9 or 10 months? Well, first, we pulled together a interagency working group from the Maryland Department of Health. We had folks who are on this call from the Healthcare Commission. We also pulled in the Maryland Department of Labor, who's doing a lot and putting some money into different training programs for folks to enter into behavioral health. And we also looped in and opened up a data sharing arrangement with the Maryland Longitudinal Data System, which has longitudinal data for higher education, graduation data, as well as employment outcomes data. Where are people working after they've gotten a particular degree or certificate? And so we pulled that group together, and we also crunched a bunch of publicly available data from HRSA, from SAMHSA, from the Bureau of Labor Statistics. We used the physician master file. We use job posting data through a tool called Lightcast, and then I mentioned the longitudinal data. And we built some kind of models to try to understand the current state of the behavioral health workforce in Maryland, and what is needed in the future. And we also did the publicly available data tells some of the story, but we also talked to about 120 people, frontline professionals in behavioral health, community-based organizations and hospitals and private providers, from psychiatrists to peer support specialists and certified alcohol and drug counselors, and licensed clinicians and everything in between. And we also talked to a lot of employers, primarily from community-based providers, but also county agencies and local behavioral health authorities, just to share with us their kind of what's going on and how the shortage is impacting their organizations or their communities or their patients, and what we should really consider in crafting some recommendations for the fund. And we heard things like this: if we don't focus on existing staff, if the fund doesn't, rather, it'll be like pouring water into a cup with leaks in the bottom. It won't work. We thought that was we heard that quite a bit, and that particular quote was pretty powerful. We also heard things kind of outside of the fund's scope, like, hey, about pay. Run back to college if you want to make a livable income. Don't become a social worker. And so what we did is we kind of put all of these conversations, the publicly available data, and just our own subject matter expertise, and put together the report. The report that you all have in your packets and that is public now is about 100 pages. The cover looks like that. And we also pulled together kind of an executive summary that's a standalone 4-page kind of bifold that hits some of the high notes that I'm going to talk about now. And so those are the two kind of project deliverables that will go to the legislator, and I know will be folks in the public will be interested too in what we found and what we are recommending. So what did we find? So one, I guess, spoiler alert, the behavioral health workforce shortage is big, and I'll define some of those specific occupations. But in the state of Maryland today, we estimated there's 34,600 or so behavioral health professionals working in community settings, hospital settings, private practice, other specialty settings, outpatient and inpatient, working in Maryland today. And just looking at kind of need and unmet need with some of the SAMHSA data, we estimated that that's about 18,200 workers short of what would be needed if all the people in Maryland who needed and wanted behavioral health services actually got it. And then we also looked at retirements, people leaving the field, and developed what we call in the workforce world a replacement rate. How many workers need to be replaced over the next 5 years? And we estimated that number to be about 14,600. And so all told, kind of the headline in terms of estimating the extent of the shortage is that number in the kind of forest green up top, 32,800 more workers are needed over the next 5 years. That is to meet the workers or meet unmet need today and replace those leaving the field. So we're talking the scope of the challenge is pretty substantial. We went through those estimates and those models for these occupations here on the left in terms of kind of defining the behavioral health workforce. The first several down to psychiatrists are kind of what I would call some core behavioral health professionals, your prescribers, your licensed clinicians, and some of what the legislation referred to as your paraprofessionals. And then we also pulled in some estimates of nurses working in specialty in behavioral health settings, as well as some other kind of adjacent occupations like community health workers and occupational therapists. And so we built those estimates kind of with this universe of occupations that we use to define with a pretty broad definition of the behavioral health workforce. A few other things we found in just the landscape, professionals are not evenly distributed across the state. Many of you probably know that. The biggest concentration is the city of Baltimore by far, per capita. Prince George's, Carroll, Charles, Calvert, Worcester, Queen Anne's employ the fewest per capita. So large and small counties were at the bottom of the list in terms of behavioral health professionals employed per capita in their geographies. Most behavioral health workers are female, except psychiatrists. In fact, a lot of the community-based providers we talked to were really looking for men, therapists and licensed clinicians and social workers to work with some of the young men in their communities. And so that came up quite a bit in our interviews. And we also found that Black workers were underrepresented among higher paying behavioral health professions, including psychiatrists, NPs, and psychologists, but overrepresented compared to the share of the population among some of the lower paying professions, such as peer support specialists and other unlicensed, roles that the legislation talked about as paraprofessionals. And we also found Hispanic workers, a growing population in the state, were underrepresented across the board in all professions, and in fact, in every single county compared to their share of the population.
What is the reason? Is it the reason is we don't have African-American and Hispanic people who are, qualified for these jobs, or there is some other reason for this?
I think the reasons are probably complex, but not probably, they are complex. But one big reason is that we've heard, at least in our interviews and have some evidence to support, is the cost of education and unpaid internships and practicums, kind of going through the system and getting employment in some of these fields is a major barrier for many people in low-income families in particular. That was talked about, that this was not even something that they wanted to pursue because of the cost of entry, and so that was kind of one reason. But I think there's a long history of kind of inequality in education that is playing here too. So I want to acknowledge that as well.
Thank you.
For psychiatrists, one thing that we've wanted to call this out here, a lot of this data is from the AMA physician master file, but at least across the state, there was, I don't know if you can see my cursor, but in Maryland overall, there was just over 19 or so psychiatrists per 100,000 residents, which is above the, maybe outdated, I think could be argued, but widely used benchmark of 15.4 psychiatrists per 100,000 people. But as you can see, like really broad ranges by jurisdiction, local jurisdiction, in terms of the number of psychiatrists practicing per population. And so I think from a workforce standpoint, the report talks about the psychiatry pipeline a little bit different than some of the others, whereas some of the others were really talking about new entrants into the field. In psychiatry, we really think it's about geographic coverage, which is, with the inequality in terms of geographic distribution on the left. Replacing those leaving the field, one of the older professions across all the professions that we looked at with the highest rate of retirement risk. And in fact, the number of psychiatrists expected to retire in Maryland over the next 5 years outpaces those who are being trained in the 2 residency programs. Representation, we talked about that a little bit, but there's fewer Black, Hispanic, and female psychiatrists in the Maryland workforce than the population overall. And then, as you all are very much aware, services to patients receiving publicly funded care. So thinking about specialized fellowships, residency rotations, and other incentives to support more psychiatrists to provide care to people regardless of their ability to pay. Psychiatry has one of the highest rates of all physician specialties in kind of cash only practices. And so that's certainly that came up quite a bit in some of our conversations. The other thing we looked at, and this is from some of the data from the Longitudinal Data Center, that and this is Maryland College and University Master's Degree Awards in social work, clinical psychology, and counseling and therapy. Starting in 2014 into the COVID-19 pandemic, there was kind of a pretty gradual increase in master's degree awards from Maryland College and University. And then after COVID-19, after 2019 and that peak, degrees just haven't recovered. And so at the same time that COVID increased the demand for behavioral services and licensed clinicians, the education system in Maryland was awarding fewer and fewer degrees and still hasn't recovered. And in fact, we looked at where some of these graduates are going from some of these master's programs. And this is just looking at the 3 social work programs 1 year and 5 years after degree completion. And we estimate it looks like less than 10% of those graduates are working in specialty behavioral health settings at 1 year and 5 years after, with the majority working in either not visible in the wage file, meaning they're either not working or not working in Maryland, or working in other industries. And we saw social MSWs working in finance and in commercial real estate and technology companies and firms. And so that's just even in addition to kind of graduates from MSW programs decreasing over the last 5 years, very few of those graduates even are working in specialty behavioral health settings. A few other quick trends in some of that Maryland College and University graduation data that we looked at. In the nursing field, a trend towards more advanced degrees, which is that top bullet over the last 10 years. But those nurses with more advanced degrees are less likely from the data to be employed in especially mental health or substance use disorder programs, which becomes a big problem for overnight inpatient rehab facilities, for example, who can't get enough nursing staff to to open or to operate. But we saw only about 2% of nursing associate bachelor's and master's and doctorate degrees were employed in especially behavioral health settings 1 year after graduation. So very few nurses are opting into these settings. Also bullet 3 there that talked about this a little bit, but the majority of master's grads are not working in specialty behavioral health settings. And then finally, definitely see a big opportunity for community colleges to play a bigger role in training and certifying peers and addiction counselors. They're just the degree awards that they were awarding in those fields were just not close to the number of professionals that are needed. We heard that from some of the employers too, that they see their local community colleges as a potential really important source, but they're not actually graduating very many folks. Okay, what can be done about it? The kind of crux or the core of the report is summarized in this table. And how we built this table was through all of the data that we reviewed and all of the 120 or so folks that we talked to. And we built this through kind of 3 steps. So the first step is actually looking at each of these different programs or investments for consideration and understanding like how many workers, additional workers are actually needed to meet the need in a given occupation. And so step 1 was looking at the gap between the workers now and the number needed for each occupation. Step 2 was kind of developing program models based on the interviews and the challenges and the education pipeline for those given occupations, and what's working in other states and what's might be working in Maryland that could be expanded. And in the report, we outlined kind of a full program model for each of these investments for considerations, as well as case studies and examples from other places that are doing something similar. And then we outlined kind of the cost per worker to train and educate a professional in that particular area, based on kind of current grant programs, interviews with training partners about their costs and their outcomes. And we also looked at kind of public RFPs from other states and looked at how much they're paying for a given outcome. So we outlined 8 programs for peers, alcohol and drug counselors, social workers. We recommended expanding some student loan opportunities for professional counselors and social workers. Looked at nursing and psychiatry fellowship and residency programs. We can kind of go deep on any of these, but in the report, there's 2 to 3 pages on each of these on how they could work, what metrics to expect, and examples from other places that are doing something similar. And so that's how we kind of stacked up to get to the kind of fund recommendation on what's needed. So the kind of headline number is to train all of these folks in these programs and get those outcomes on the number of workers impacted on the bottom right. We estimated cost 148.5 million over 5 years. But we built a kind of a capital plan based on a few different sources. And so that green part of the bar with the call out number of 59.5 million, that's kind of the catalytic down payment or the investment that we're recommending to the legislator over 5 years. And we outline a few sources they might want to consider using, including opioid settlement money that other states are using for similar investments that could really, in our mind, unlock kind of other funding streams. And so going from the green circle down to the left, we identified kind of potentially about 24 million over 5 years from the Department of Labor and from other agencies that could be used as leverage, kind of with some interagency kind of commitment and partnership to go along with that initial down payment to expand the impact in a couple of key programs. We also outlined some specific competitive federal grants that we think the state is very well positioned in to advance the kind of recommendations in the report. And then there's some recyclable revenue and potential philanthropic opportunities that we outlined that could be used to get to that full amount. And so we wanted to be pragmatic about this. You know, if the legislator just had 150 million to write a check and be done with it, it'd be a lot easy, but that's not quite realistic. We wanted to kind of give a roadmap for how some new money plus some really specific kind of commitment and alignment across agencies could actually make this thing go. And in the report, we kind of outline which funding stream matches which program and that sort of thing. The last thing that I really want to say today before opening up for questions is what we heard quite a bit in our interviews, and it's really clear in the data, is that the training fund is a critical investment and we think will be very impactful if it's as a part of a kind of broader workforce strategy across the state. So we heard and outlined kind of 6 core pillars of what a statewide behavioral health workforce strategy could look like. And front and center, number 1 is competitive compensation. In some fields, the differences between a community behavioral health salary and a private practice salary are just so great that a scholarship might simply not be enough to close the gap for a lot of people. And similarly, there are several occupations that we looked at where people need to work 2 full-time jobs to pay rent and put food on the table. And that's a pretty tough situation to be in, regardless if you're getting a scholarship or some loan forgiveness. And so we didn't want to shy away from that and a few of these other things that we heard quite a bit about as being important, including timely and effective licensing and opportunities to expand the impact of the current workforce through collaborative care with primary care physicians, for example, to help meet the need with the existing workforce. But we wanted to kind of give our recommendations in context of a broader strategy for the state. And so the report outlines some of that. And then finally, we give some kind of operational mechanics to how kind of the Department of Labor, the Maryland Department of Health, and some other agencies kind of with executive leadership could go about administering the fund in an effective way. I'm going to stop right there and open it up for questions on the report or anything I said. Thank you.
Thank you.
Hi,
Sure.
hello. This is Commissioner Blake. Can you hear me?
Yes.
Hi,
Go ahead, Commissioner Blake. Why don't we have the discussion before the motion? It is a report. So.
Just a report.
Yeah, go ahead.
okay. Thank you for the presentation. I just had a quick question. You had mentioned compensation. Can you talk a little bit more about some of the findings that you found about compensation as it relates to people entering the field and staying within behavioral health as a profession?
Yeah, I would say kind of across the board, like especially publicly funded behavioral health compensation doesn't stack up to what a social worker, for example, could get you know, at a large hospital compared to a community behavioral health provider. Same for obviously a psychiatrist taking, you know, a large panel of Medicaid patients compared to private practice. And so what we heard and what we found in the data was comp really, it affected, it was all, people were all like generally not across occupations had problems with compensation as a major talent attraction and a retention issue, but in different ways. So for peer support specialists and alcohol and drug counselors and other paraprofessionals, there's evidence that a majority of them, I think it was 75% or so, don't actually make a living wage on a full-time job in their role in Maryland. And so like many of them are working 2 full-time jobs. So maybe as a peer support specialist and then working in retail or food services just to pay rent. And I think that's not kind of what we want for the system of care. For social workers and professional counselors and therapists, a lot of the comp was related to what they perceived as low for their student loan debt and obligation and what they came out of pocket for. So we heard a lot about, so some of these folks are making 50,000 or so out of college after maybe carrying $75,000 of debt or more to get through their master's program and doing a 6-month unpaid internship. And there was just this feeling of, okay, we made it, we're on the other side, we're now working in community behavioral health. But I can barely service these loan payments and make ends meet. And we also heard a lot of frustration with some of the federal, in particular, student loan forgiveness programs that they thought was going to take care of them. And then as you go up the food chain, I guess, or like the wage level, I should say, most of the compensation issues for psychiatrists and NPs was the difference between Medicaid patients and private practice. I should say also just cost of living adjusted wages for all the occupations we looked at in Maryland was lower than the surrounding states, Pennsylvania, West Virginia, mostly because Maryland's more expensive to live.
Commissioner Boyle?
Yeah, hi, Commissioner Boyle. Thank you. It's a good report. I guess I have 2 observations. So many of the reports I've seen through the years underscore competitive compensation. And what are the chances in this field of, at least being equal to the salaries in surrounding states that you outline? I mean, what steps have to be taken for that?
Yeah, so I would say we wanted to acknowledge it because it's kind of the elephant in the room, and it's obviously there's advocacy and rate reimbursement and reform and other efforts that have been long underway for decades. Exactly outlining how to get to a more competitive comp, I would say, was a little outside of our scope and structuring the fund focus areas, but we wanted to make sure that we acknowledged it because it is an elephant in the room. And then B, our focus was kind of figuring out how the fund could buy down the cost of entering and staying in the field, despite comp being maybe not where it should. So that's probably not a satisfactory answer, but there's probably smarter people I know there's smarter people in the state of Maryland who've been working on this for several decades on pay parity and reimbursement reform, but we didn't get too far into that in our scope. But that's
and this is not as I guess critical, but the promote timely and effective licensing. I know somebody who went through everything for the master's program and then offered a job ready to go, and then it took about 3 months for the with all the paperwork in for the license. And, pretty much was told that this person was lucky because it can take a lot longer. It seems to me that's something that wouldn't be as hard to achieve.
Yep. Yeah, numbers 1, 2, 4, and 6, we felt are like they're not money issues, they're policy and practice decisions and process improvements. So, but we heard that loud and clear that the licensing, especially for the counselors and therapists, is a major barrier that needs to be addressed.
Commissioner Brzezinski, so.
Yeah, I think, to follow up on the wage question, we're a lot of the language in healthcare policy now speaks about healthcare equity, about bringing services to people who are suffering health disparities due to, a lot of socioeconomic factors, social determinants of health and so forth. Many of those patients are Medicaid patients. And if we have a state where, this is where the rubber meets the road. We have a state that wants healthcare equity. State pays for Medicaid. You want equitable care for your Medicaid patients? Then you need to pay the providers equitable wages, competitive market wages to care for those patients. Or you just continue to accept that Medicaid patients are going to get inequitable treatment and have inadequate access to the care they need. And, that's why, you know, it's a great and lofty goal. It's a just goal to pursue healthcare equity across all populations to raise the health of all Marylanders. And I fully support that. But understand the initial upfront investment that's gonna cost. But as a clinician, I would say, if we do have adequate mental health resources, if we do have attention to social determinants of health, if we do enhance primary care and promote healthy provider-patient relationships in the Medicaid population, we should see some decline in some of those high-cost utilizations of ER visits and hospitalizations and so forth. It's not going to happen in the same budget year, which makes accountants and actuaries twitchy. But, you know, this is where the rubber meets the road. So for anybody who's listening, who has more opportunity to direct funding to the care of Medicaid patients, this is a very clear example of investment that would help improve equity for our Medicaid patients, as opposed to telling providers, provide more equitable care, but we're going to pay you inequitable wages to do that. And, you know, dollars drive decisions. And if there's not a financial funding commitment to this, then simply the discussion of health equity is just lip service, and it's going to fall flat and be revealed to be, you know, pointless propaganda, as opposed to meaningful policy change to improve the health of our fellow Marylanders. So.
Oh, I'm sorry.
That wasn't a question.
Go ahead. You've been waiting for your soapbox.
Commissioner Jensen, first of all, I agree with Commissioner Bazinski that if we want healthcare equity, you have to spend money to get that. But I have two questions. One of them is, how does the report address the issue of various groups being underrepresented in the licensed healthcare professionals, and addressing that, number one, and number two, how does the report address keeping people in the practicing in this area after they get out?
So, say that the second part of the question, it cut out a little bit for me.
Well, the first question was, how does the report address getting underrepresented groups into schools, out of schools, and practicing behavioral health? Number one. Number two, how does the report address the low retention rates for people who have graduated, gotten a degree, and practiced in behavioral health?
Yeah. So a lot of those, we designed these investments for considerations that are back on the screen now. These kind of 8 programs with those 2 primary questions in mind. So, for example, some of the program designs for these investments would be further fleshed out in like an RFP process that the state would put out for training providers in schools and colleges to apply to. But we outline language for kind of preference points and evaluation criteria for schools and training programs that have a track record of outreaching to, enrolling, and having good educational outcomes and job placement outcomes for some of those same demographics that we found were underrepresented in the behavioral health workforce today. So that's maybe point one. I think.
Okay, so let me just follow up on that one real quick. So in the report, then you're saying that the descriptions that are on this chart here don't really bear that up. You're saying in the report, it drills down further and suggests that that's what these programs would do?
Correct. That's what I'm.
Okay, got it.
And then so that's like one objective, right? Getting a bigger, more diverse talent pipeline coming into these fields in various different ways. But your second question was like, how do you get these folks to stay? So one of I'll kind of draw your attention to kind of that middle program called Community Behavioral Health Talent Attraction and Retention Grants. And there's an asterisk at the bottom. One of the things that we know in the literature, and we also heard quite a bit from interns is that, or from interviews, is that having kind of a high quality supervisor and mentor with time and energy to actually go through your caseload, work on hard cases together, and build that kind of real personal, productive mentorship relationship. Not only is a requirement for like getting those hours is a requirement for licensure for many occupations, but also is very much connected to retention in a given organization. And we heard so many times from community behavioral health organizations that someone who's trying to do supervision also has a caseload of 100 or 150 clients, and they're also managing a grant program, and they're trying to supervise a couple of clinicians or some interns from the master's program kind of at the side of their desk, and that just doesn't work long-term for both the supervisor and the intern. And so we put aside a significant amount of money, that $50 million there, for community providers to really build their kind of retention and their recruitment kind of structure internally, and make some of those what I'd call job quality investments to make their workplaces better places to work that have better metrics on talent attraction and retention. That's just one example with that supervision example, but that's what we were trying to get at with that investment there in the middle.
My takeaway here is that if you go back to your slide on how many more behavioral health workers we're going to need, just under half of them are people who leave the field. And I've seen a lot of data in here that suggests that people are getting severely underpaid. So perhaps more emphasis on, the way, a big way to address this issue would be keep people from leaving by paying them more money.
Yeah.
And if that is a correct question, perhaps we could just connect those dots and put it in bold somewhere.
Yeah, that's front and center. I think like.
Yeah, it's front and center, but to me, in the slides, it's kind of not, you gotta connect those dots. To me, that would all be like, one slide.
If I could bring it back though, if I understand the purpose of this report is to recommend how much money to put in the fund that the state is running for behavioral health, as opposed to fixing all behavioral health problems.
But we're putting a fund together to figure out how to fix behavioral health in Maryland.
This is the wrong word. I guess.
Well, to improve, okay.
Yeah.
My word.
I understand,
But
but
the
I
only way to
think then
improve
if
is
we're
to
talking
increase the
about
pay.
how we want to improve behavioral health delivery in Maryland, somewhere it would be great if there's a little more of a focused emphasis on, you got to keep people from leaving by paying them more money. That's going to go a long way. And somewhere in there, when you're developing a fund to improve behavioral health, that would be, I think, a legitimate goal.
Yeah, I'm not arguing with the goal. Saying the report here is specifically supposed to advise the state of how much money to put in the fund, so.
Yeah, I mean, we're going back and forth. I understand what you're saying. I think that my comment still applies, but we'll.
Should be.
Commissioner Jensen,
I do also think that there's just a pay disparity upon the different counties in Maryland. So just to bring people up to the same pay across the board in the state could be helpful, because we're losing clinicians and providers to other counties because other counties are paying more.
not only other counties, Virginia is
Yeah, but other states that are
50% more to the
bordering us.
physicians. I have doctors that are leaving. after a couple
I'm
of
sorry,
years in Maryland.
I'm sorry, was the commissioner just before, Commissioner Bandari? Can you
Yeah,
identify?
obviously, it's Virginia is across the state. They are paying 15% more than the Maryland. So it's not only the behavioral health providers, it's other providers also, like, family doctors and other physicians and nurse practitioners. They're leaving, or they live in Maryland, they work in Virginia.
So the commissioner who spoke before, Commissioner Bandari, was that Commissioner Cheatham? I think.
No,
as
that was Commissioner Alwa, Bobby.
Okay.
Yeah.
Okay.
Oh, thank you.
So if the commissioner is on the phone, before you identify yourself, because for meeting minutes and for the benefit of everyone in the room, we don't know necessarily who's speaking. If you can identify yourself, and the commissioners here will do likewise.
Commissioner Gilbert?
Just a quick comment to again underscore the importance of compensation. When I was a hospital vice president and we were hiring all different kinds of folks, social workers have to have a master's to work in a hospital. And the master's degree social workers were making about between 2/3 and 3/4 of what an associate degree nurse was making. And that isn't abnormal at all. So there has to be some parity in terms of compensation for folks.
So we all agree, can this be underlined a little more, the dots connected as Mark indicated?
Honestly, I don't disagree that it's an issue, but I don't agree that we should take the purpose of the report and reformat it into a let's restructure compensation. It does point out the disparities in compensation, and it does do those things. And then it goes on to talk about how much money is supposed to go into the fund, which was the purpose of the report. I think that's a separate discussion that could be had for sure. But
I would agree.
I mean, I think I just wanted to make a point that I think that Mr. Hall made, you know, leading edge point one is provide competitive compensation. I mean, in the notes that we share with the legislature, I think we can, you know, emphasize that as a precondition in a sense, because the fund is premised on the fact that you don't have this ongoing churn forever where you're training, but losing 70% of the workforce because of inadequate compensation. I think that's the important point to also be sure that it is elevated. And I can see someone's telling me to elevate my voice as well. But I think I think the entire report does put a pretty heavy emphasis on the importance of compensation. I mean, the first thing that what I walked away from was the small percentage of mid-level behavioral health specialists who are not earning a living wage. That speaks to the question of that's the first condition that I think has to be identified and remedied.
So I agree with everybody, but when I look at the slide that talks about the investments for consideration, there's nothing about compensation in how this money was identified, the 148.5. Like it talks about peer recovery training and placement, alcohol and drug counselor, social worker learn and residency programs and what have you. But where, if we didn't address it in this report of how much is needed, we did. We didn't address compensation or how much would be needed for that in this report. And it's the leading thing when you look at the list. It starts with compensation.
And I mean, I think that the grant program was intended as a initiative on the part of the state, not Medicaid, not commercial payers, not Medicare, but what additional steps we can take. I think the issues of compensation go back to, is Medicaid going to pay more? Are commercial payers going to pay more? Are the various social service organizations that employ mid-level behavioral health specialists in particularly, you know, local health departments, are they going to pay more? But the grant program itself cannot be, you know, a fund that necessarily that takes the underpayment, payment inadequacy, and makes up for those gaps. The appeal has to go back to payers, including Medicaid, including local health departments, including, you know, the commercial payers, to look at reimbursement comparability with other clinicians and make those adjustments. I don't think the grant fund should do that. It seems like that would be something like a supplemental fund but it's a precondition to the grant fund working. Compensation has to be reevaluated across all the payer communities that use behavioral health services.
Can we ask for next step being an analysis of that? So
Well, I think we're doing some of that shortly, so stay tuned on, payment adequacy for behavioral health and telehealth primary care services. Good. I think these two reports kind of fit together in some ways pretty well, but those questions, I see this study as somewhat independent of the compensation issues, but they fit together pretty well. So, I mean, I think we can put a greater emphasis, in the letter that accompanies this to the legislature, emphasizing as a first step that we can't lose the awareness that many of these, especially mid-level providers, are not paid a living wage. And that certainly doesn't encourage putting down roots and continuing in the profession if you want to start a family, et cetera. So I think we can say that, but I don't really see this as a study that looked at compensation. I think it looked at how could we enhance the workforce. Precondition is that payment has to be. I don't disagree with Commissioner Jensen or any of the other commissioners who weighed in on that.
Just so folks know, section 4.1 is in the report is entirely about compensation. So we're not really voting on slides. We're voting on. So I think I lost my page, but I think 97. Yes, on 97 is the only place I saw where we really broke down where we're asking for the money. Is that right?
I believe so, yes.
And on that one, it says 59.5 million of down payment over 5 years. Is that, I mean, we're going back to the legislature. I'm assuming this is saying you're going to need to put some money into this fund. We're saying 59.5 million over 5 years as new money. Am I reading that correctly?
Yeah, that's like the new general fund money, or again, many states are using opioid settlement money, and we're kind of giving them a roadmap in the following pages around how you use that new money over 5 years to leverage these remaining sources to get to your number.
And there's 45 million philanthropy, 19.8 million in competitive federal grants, and 24.2 million of existing federal and state funds. Who, I mean, it may be beyond your remit. Who is getting that money? In other words, all of those sources involve someone going to collect the philanthropy, someone filing grant applications, someone redirecting funds.
Yeah.
Does your plan sort of envision funding for obtaining that funding?
Yeah, the kind of implementation roadmap outlines kind of a 10% or so amount of that 59.5 million to establish the kind of interagency working group to set up the protocols for securing, administering, and distributing these funds, managing outcomes. There would be contractors and RFPs to be put out and managed to make sure they're training the people they say they're going to train and all that stuff. So that would be, I think, exactly how that is structured and sits is to be determined, but the report gives some concepts of how that could be, how folks could go about that in the state of Maryland.
And then this comes out around $12 million a year. I assume if the state said, no, we want it to be $24 million a year, we would find ways to use that to improve behavioral health. How did you draw the line between the programs that didn't make it into that 12 million number and ones that did? What was the metric there? Were you working towards a number that seemed practical and achievable? Or were you working towards what programs would work best? How did you decide to leave things out?
Yeah, it was a combination of those two things you just said. We wanted to be practical and give the legislator something that we knew in the current budget circumstances and the budget year and the available potential sources could be doable and is not just rejected out of hand, because then that's not really helpful for anyone, just to say, you know, $1 billion would be nice. But we wanted to also, and then the programs that we selected were the short list of the ones that were on the screen there in a second ago, were we wanted to have at least one program for some of the highest priority occupations that we heard from employers of having the hardest time filling. And so we wanted at least one program that was focused on attracting and retaining folks in those occupations. And then we selected the types of programs based on the evidence, or at least promising initial data from programs that are either on the ground in Maryland that could be expanded, or that are happening elsewhere that have some evidence of success, or some promise of success from a workforce standpoint, which is more people graduating and more people staying in publicly funded behavioral health settings.
Thank you. Any other commissioners have questions or comments? Ben?
I just want to make, a point that this was very much shaped by the fact that the state's economic picture is not as bright as it has been in some years, and recognizing that there was an appetite to do something, but everyone recognized that everything that they would like to do couldn't be done in the next several years, given where the state stands with its budgetary outlook. I think the key point here is that all of these are referenced as down payments, that more is needed. The state can make a down payment, an initial payment. There are some opportunities for additional add-on fundings from other state or federal and philanthropic sources that should be tapped. And I think that's, given where we are with the budgetary picture, probably a pragmatic way to go, to tell legislatures that there's intentions to get money from state sources, but other sources would be examined too.
Thank you. At this point, can I get a motion to approve the behavioral health workforce assessment report?
Marcia got it.
Okay, Commissioner Boyle, can I get a second?
Second.
Are there any final questions, discussion, comments? All in favor, say aye.
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 Oops, I'm sorry. Wait longer. Are there any opposed? Great, the motion passes. Thank you for the discussion and for the report.
And Chairman, just to confirm what we said a moment ago, that in the cover memo typically accompanies these reports, will make a point that the commissioners emphasized that equitable compensation for all of the behavioral health professions are going to be essential for any grant program to have long-term traction.
I have no problem with that. I just didn't want to dilute the focus of the report. All right, agenda item number 6. Telehealth Recommendations Report, SB 534, Preserve Telehealth Access Act of 2023 and HB 1148, Behavioral Healthcare Treatment and Access. The General Assembly passed legislation in 2023 requiring MHCC to study and make recommendations on the delivery of healthcare services through telehealth, including payment parity for the delivery of healthcare services through audio-visual and audio-only technologies. Justine Springer, Program Manager, Health Information Technology, will present findings and draft telehealth recommendations to the General Assembly by December 1, 2024. Justine, please proceed.
Thank you, Chairman and Commissioners. Before I discuss the 2023 legislation just mentioned, I have one slide that provides some background on 2 prior telehealth studies. Next slide, please. The Preserve Telehealth Access Act of 2021 required MHCC to study the impact of audio-only and audio-video telehealth in the delivery of somatic and behavioral health services. A final report included a recommendation to continue payment levels for telehealth services relative to in-person care for 24 months to allow additional time to further study the extent telehealth affects quality and cost and its impact on health equity. This recommendation informed the study provision in the Preserved Telehealth Access Act of 2023. Staff also conducted an interstate telehealth expansion study at the request of the Health Government and Operations Committee in 2022 after legislation was withdrawn by bill sponsors. A final report included recommendations that build upon Health Occupation Board's efforts to enable alternative pathways to licensure, such as compacts and reciprocity. Next slide, please. In 2023, legislation was passed extending payment parity for telehealth through June of 2025. The legislation tasked MHCC with conducting a study and making recommendations regarding the delivery of somatic and behavioral health services through audiovisual and audio-only technologies, including payment parity. The study scope included 4 questions required by both bills, Senate Bill 534 and House Bill 1148, and these questions will be discussed in subsequent slides. Next slide, please. Milliman, Inc. was competitively selected to answer the study questions by conducting an analysis using private payer, Medicaid, and Medicare data from MHCC's all-payer claims database. Milliman produced actuarial models to examine telehealth and in-person reimbursement rates for services delivered by behavioral health and primary care providers. Milliman developed 2 technical reports based on their findings, which informed development of telehealth coverage and reimbursement recommendations. Technical Report 1 compares telehealth and in-person services by looking at the average allowed cost for clinical intensity for services. Technical Report 2 compares reimbursement rates as a percentage of the Medicare physician fee schedule for somatic and behavioral health services delivered in person and via telehealth. Next slide, please. I will now overview some key insights from Milliman's analysis for each of the 4 study questions that are listed in the slides that follow. Representatives from Milliman regret not being able to attend the October Commission meeting. Unfortunately, the team that completed the studies are traveling and were not able to rearrange their schedules. In a review of the literature, Milliman found that the cost to deliver telehealth services compared to in-person are inconclusive. Some costs are fixed regardless of modality, such as malpractice insurance and certain overhead expenses like rent. Other costs are variable based on the patient's condition, the provider type, geographic location, and care site. There is significant variation in the literature with how costs are defined and reported, making general cost effectiveness difficult to determine. Audiovisual telehealth is generally reimbursed consistently across different provider types in rural and urban locations. Milliman's analysis found that the relative reimbursement for audiovisual services was consistently greater than 100% when compared to in-person, except psychiatrists in rural locations. Greater than 100% means higher reimbursement for telehealth compared to in-person, assuming work, practice expense, and malpractice are all the same regardless of modality. A direct comparison of costs between audiovisual and audio-only telehealth requires further clinical assessments. It was found that more research is needed to quantify implementation costs for telehealth, particularly hardware and software installation, such as cameras, computers, monitors, wireless internet connectivity, and specialized digital medical equipment. Next slide, please. Milliman's analysis showed the relative clinical intensity of care for services delivered in person and using telehealth depends on the type of service being delivered and the type of provider delivering the services. For example, it takes more time to assess injuries and other physical symptoms via audiovisual telehealth versus in person. Other studies show that for urology and general surgery, physician-led video visits took longer compared to in-person. However, physician assistant-led visits took less time on video compared to in-person. Milliman's analysis showed trends of a decrease in the relative clinical intensity for behavioral health services and office/outpatient services delivered via telehealth compared to in-person, with little difference between urban and rural locations. Generally, the relative clinical intensity levels are lower for audiovisual and audio-only services, with the exception of psychiatrists in rural locations. Milliman identified several sources of variation that may cause differences between telehealth and in-person services, such as service mix, carrier reimbursement mix, provider mix, and area mix. Next slide, please. Assessing overuse or underuse of telehealth services would require a definition of what the clinically appropriate levels of telehealth use, and this was beyond the scope of Milliman's analysis. Milliman conducted an analysis to identify differences in telehealth utilization by lines of business, prior years, and behavioral health versus primary care. While the analysis showed that telehealth use is higher than prior to the pandemic, there is no conclusion that this is a result of overuse. It does suggest that the market capacity to provide more services via telehealth is greater than prior to the public health emergency. Some research suggests that telehealth can replace some in-person care, and other research suggests it can be additive. The research suggests that services may appear additive, but are representing closures of gaps in care where telehealth is enabling patients to access services they previously were unable to access due to provider shortages. Telehealth may be subjected to underuse where technical limitations may exist, such as lack of broadband access or devices inhibiting the use of telehealth. Milliman's review of the literature showed increased use of telehealth is attributed to its demonstrated value to improve access to care. The literature shows that telehealth helps improve health equity through improved access to behavioral health services, especially in rural areas, and where barriers such as transportation, childcare, and limited time off work may limit care. More research is needed to evaluate the cost benefit of using telehealth for behavioral services at scale, which was beyond the scope of Milliman's analysis. Next slide, please. Milliman's literature review showed that reimbursement for behavioral health services is lower than somatic care, which is generally attributed to disparities in funding, differences in market dynamics, and perceived differences in the complexity and duration of behavioral health treatments. Milliman conducted an analysis to evaluate the differences in reimbursement for telehealth services compared to in-person by comparing telehealth reimbursement as a percentage of in-person care. The analysis showed that primary care services delivered in person and using telehealth were higher for private payers and Medicare Advantage plans compared to reimbursement for behavioral health services. Given the ongoing role of telehealth, further monitoring and analysis is needed to ensure policies are equitable and virtual options remain available for providers and healthcare consumers. Next slide, please. So this slide highlights some findings from national research that show telehealth visits are comparable to in-person visits for most somatic conditions. For behavioral health, telehealth is generally considered to be equivalent in terms of quality and health outcomes. Telehealth has been found to be associated with fewer in-person visits, and its use helps address gaps in care. Reimbursement for behavioral health services has historically been lower than for somatic care. Next slide, please. So for the next two slides, I will provide an overview of the telehealth landscape today and the legislative trends at the federal and local levels. Next slide, please. Overall, telehealth use has declined since its peak in 2020. However, as mentioned previously, its use remains higher than prior to the public health emergency. The majority of telehealth services are delivered via audio-visual technology, and only a small percentage of services are delivered by telephone. Use of audio only is more common in vulnerable populations to ensure access to care. The proportion of services delivered via telehealth is far greater for behavioral health services, over 60%. And these virtual options help to promote health equity. Next slide, please. States and private payers have largely followed federal telehealth policy changes that relaxed rules on where telehealth could originate, what services were reimbursable, and permitted modalities. In July, CMS released the 2025 Medicare Physician Fee Schedule proposed rule that permits the continuation of telehealth on a provisional or permanent basis. One notable change is the expansion of audio-only options to all patients on a permanent basis, whereas the current rule only allows audio-only for behavioral health. Next slide, please. I will now overview the 3 telehealth coverage and reimbursement recommendations. Draft recommendations were shared with select stakeholders, including providers and payers who expressed support for the recommendations. Next slide, please. The first recommendation is to allow use of telehealth by any healthcare provider licensed, certified, or otherwise authorized under the Health Occupations article to provide healthcare in the ordinary course of business or practice of a profession or an approved education or training program, or for interprofessional consultation. This recommendation promotes provider and patient choice in when to use telehealth based on the patient's needs, which may address geographical and logistical barriers to receiving care. Broad acceptance of telehealth across various specialties and settings, and high utilization of telehealth to deliver mental health and substance use disorder services improves equitable access and continuity of care. Next slide, please. The second recommendation is to allow unrestricted use of audio only for behavioral health telehealth services based on patient consent to receive care via audio only technology. Allow use of audio only technology for somatic care if the provider is technically capable of using telehealth, but the patient is not capable of or does not consent to the use of audiovisual technology. Audio only telehealth accounts for a small portion of all telehealth services. In 2023, audio only accounted for 9% of all somatic telehealth services and 0.1% of behavioral health telehealth services. Allowing use of audio only ensures that patients are able to access behavioral health services. This benefits certain patients who may lack audiovisual capabilities. Requiring physicians to have the technical capability to support audiovisual services for somatic care sets the standard for telehealth that prioritizes visualization when possible. Next slide, please. The third recommendation is to maintain payment parity for behavioral health and somatic care delivered using audiovisual and audio-only technologies. This recommendation helps ensure virtual options remain a practical option for providers in providing patients with equitable access to care. Telehealth services have been shown to be a viable option in receiving care. Reimbursement that is at least the same as in person helps ensure continued access to care. Next slide. This concludes my presentation. Staff proposes the commission accept the draft telehealth recommendation reports as final.
So the whole thing.
Commissioners, any questions or discussion, comments?
Before or after the motion?
Well, we have one, we've got it both ways so far, so.
Which way would you like it, or I'll ask my question.
Well, we'll do reports with the discussion first, so that, go ahead.
Second that.
Thank
Robert
you.
will come hit me over the head with his rules of
A lot
order.
of work went into this. Thank you very much. The statement was made, and I remember looking at the report, that there's increased, it's kind of counterintuitive to me. There's been increased reimbursement for telehealth than in person. That statement early on in behavioral health. And that's a little counterintuitive. Why would there be, I think it's starting to even out, but why would there be increased reimbursement for telehealth than for in-person?
So I think what you're talking about is, yeah, so there has been an increase in services delivered via telehealth. So there's been a relative increase in the reimbursement for telehealth services.
So if someone's seeing someone, if you're seeing a counselor by telehealth or in person, the reimbursement isn't necessarily better for telehealth. That's what I'm
No,
trying to
there's
understand.
payment parity, so it's the same. Yeah.
That's what I thought, but then there was this statement.
Just doing more telehealth and payers are paying more for telehealth.
That
There's a greater
that
increase
makes
in telehealth
sense.
than there has
The
been.
volume.
Right, now it accounts for behavioral health. The majority of services are now being done via telehealth versus in person. It's 60% to about 40%.
So just to build on what Justine said, I think she answered it well, but a little more perspective here. So the analysis was done by actuarial firms. And what they did was they used the average cost per grouping of how it's structured in the VITO system. So they said the average payments for this service mix and this geographic area is blank. And so if services are calculated in terms of the total that span across geographic mix or service categories, because these are considered to be groupings, or they call them families. But if it spans across different service areas, your actual average, you look at averaging it up, is going to be, could be greater than an in-person, or conversely, less than. So it's a bit of comparing the average to the average, if you will.
Thank you.
But I think Justine's answer was pretty much very good point on, but just a little.
Any other questions?
This is Commissioner Bandari on recommendation 2. Can you clarify for the behavioral health audio only? And for the somatic health, you need audio visual. I'm under the impression, you know, I did my psychiatry rotation also. You really need to see how the patient's affect is, how they are behaving, how their facial expression. It's very important to make any decision making and give, you know, good care. Why there is a discrepancy? On the other hand, somatic may or may not be important to have audio visual.
Sure, so I can speak to that a little bit. So for both, we're suggesting that we continue audio only coverage for both somatic and behavioral health. For behavioral health, to address your concern around not being able to see the patient, the audio only is only used for 0.1% of services. So this suggests that these are very vulnerable patients. So we wouldn't want to necessarily say that they cannot receive audio only, considering its very low utilization. And the same for somatic, we're asking the provider to be able to have the technical capability to do audio visual, which prioritizes seeing the patient when possible, but again, not limiting it completely or saying you can't access the service if the patient doesn't consent to audio visual or can't technically access audio visual technology.
Well,
Did that answer?
yeah, you answered. I will give my another comment to having audio visual. If you use once a week or twice a week for the patient convenience and you pay for the services, that's a lot for the providers. Many of them will not do. That's what I'm trying to say. Why even the providers have to have audio visual and pay for that when they may not utilize, and they are doing mostly for the patient's convenience. I love patients to come here, drive 50, 60 miles or 40 miles, pay for the gas and wait in the waiting area. But that's not really we should do for certain cases where we want to provide good care. So there should not be this mandate, like you have to have this you have to have this audio visual capability for the providers.
So could I add additional commentary here? These recommendations generally parallel what's in the Medicare physician fee schedule 2025. This specific recommendation around using telehealth for audio and audio visual, and the requirement to be capable of doing audio visual before you use audio is straight out of the Medicare physician fee schedule. So this recommendation aligns with federal policy and what we hear from other states as well. It isn't unique to Maryland, by the way, and it also just builds on what was approved or in the to Preserve Telehealth Access Act 2021 recommendations. So I don't know if that helps, Dr. Bandari, Commissioner.
That helps. That helps. Thank you.
I mean, I think that we've been at this now for four years, really, with dealing with recommendations. The trend has been, particularly among behavioral health providers, recognition that audio only is less needed than it was once thought to be the case back in 2020, where there was an insistence that in order for patients to access behavioral health had to be delivered audio only. The trend has been the steady trend has been away from audio only to audio visual capabilities, which is kind of, I think, what I would think is a better delivery model than simply talking to someone over a telephone and trying to judge reactions. and attitudes, et cetera. I think the point that you made, Dr. Badari, is a good one, that many of the state boards have also made observations about, that it's awfully hard to judge patient reaction when you can't actually see visually what's occurring. So it hasn't gone away completely, but there is recognition that when it is now used in 2024, there are more special circumstances than there were in 2020 when we were all just trying to get used to virtual care of all types.
And it's in there, at this point for somatic care, it's in as a backstop because some people don't have broadband. Can't use it, so they can't use audiovisual. That's right.
Thank you.
Any other questions or comments?
Just make a comment that I think telehealth is sort of like a miracle for taking care of patients who we've been unable to reach. And you know, Dr. Cheatham, I don't know if you know better numbers, but when I was at KP, the no-show rate for behavioral health patients when we moved to tele visits was way less, like it went less than half of the no-shows when we moved to that. In St. Mary's County, there's about 2.5 psychiatry providers for 110,000 people. And one of those provider groups, not just groups, providers, is about 1.25 FTE, and it's all tele. So if there wasn't tele, it would only be the people who work in the hospital. So I just think that even when we think about the physical parts, there's so much more now that we're able to manage, and I just applaud it.
And I had a question, two appendices, I was reading through those. Those are actually just summaries of what we did last year, right? Those aren't actually current recommendations or anything like that.
That's correct.
So I was gonna ask a question, I was like, oh, that's the MIH recommendation from last year. I won't make you answer for the Maryland Insurance Industry.
Excellent report, very good.
There are no more questions or comments? Can I get a motion to approve and adopt the telehealth report? Commissioner Bazinski, Commissioner Jensen is second. All in favor?
Aye.
Are there any opposed? Motion carries. Thank you very much. Okay, the commissioners focus. We're all the way up to agenda item 7. Pretty meaty stuff. All right, item 7, 2024 primary care investment analysis and recommendations report. Chapter 667, also Senate Bill 734, titled Maryland Healthcare Commission Primary Care Report and Work Group 2022, requires MHCC to conduct an annual analysis of primary care and make recommendations on the level of primary care investment relative to overall healthcare spending. Findings must be reported to the General Assembly each year by December 1, 2024. Melanie Cavalier, Chief of Innovative Care Delivery, and Mary Jo Condon, Principal Consultant, Friedman Healthcare, will present the key findings and recommendations. Melanie and Mary Jo, who do you think?
Mary Jo's online, yeah. So good afternoon, Mr. Chair and Commissioners. Mary Jo will be online, and I will introduce her when it's her turn to speak during the slides. She's on screen right now. See her. Next slide, please. So as a reminder, in 2022, the Maryland General Assembly passed legislation that established the Maryland Healthcare Commission Primary Care Report and Work Group. The legislation requires MHCC to conduct an annual analysis of primary care and offer recommendations on the level of primary care investment relative to overall healthcare spending. The 2024 Primary Care Investment Analysis and Recommendations Report marks the first comprehensive analysis of primary care investment over the preceding year. The report provides an update on progress in increasing investments in primary care and offers recommendations designed to help address the urgent challenges within primary care. Next slide, please. So nationally, about 20 states have either enacted primary care investment initiatives or have them pending. The states with the longest standing primary care investment targets are Colorado, Connecticut, Delaware, Oregon, and Rhode Island. Colorado established a set of annual priorities for primary care providers and payers to guide investment in care delivery. Delaware focuses on providers engaging in care transformation activities. Oregon highlights the benefits of coordinating care across primary care and behavioral health, as well as efforts to address patients' social needs. Rhode Island has a long-standing medical home program that offers additional primary care payments. And most recently, Maryland, Nebraska, New Mexico, North Carolina, and Oklahoma established requirements for primary care targets. Those are in the process of identifying strategies to achieve those goals. Next slide, please. So the payers earlier this year were asked to complete a value-based care environmental scan. The payers collectively reported 47 APM contracts. 12 were shared savings programs with downside risk covering over 100,000 members. So Aetna reported 10 contracts, CareFirst 18, Cigna 19, and 11 of those were part of Cigna's ACO model. The payers focused their efforts to increase primary care investment largely through value-based care models. These models are primarily implemented within large health systems, often through ACO structures that emphasize population health strategies. Next slide, please. So I'm now going to turn the presentation over to Mary Jo Condom of Freedom in Healthcare to discuss the key findings and recommendations.
Thank you, Melanie. It's great to be here. First, thanks to Ken Yates Trotman and the data team at MHCC for conducting this analysis that I'm going to share a little bit with you today. Before we dive into the results, I wanted to provide some background on the analysis and a few caveats. So the first is that the data comes from MHCC's all-payer claims database. The years used for the analysis include 2020 to 2023. And the analysis included claims from private payers, Medicare Advantage, and Medicare fee-for-service. We wanted to note that data from the year 2023 includes 9 months of allowed claims incurred through September 30th of 2023 and 3 months of runout claims. So a little bit less than a year there included for the most recent year of 2023. I also would like to note that data was segmented by zip code and county, and an analysis was conducted on primary care investment relative to total healthcare spending from the previous year, both overall and by payer. As you'll see, the data also includes an analysis of primary care spending on a per member per month basis. All
Come
major
on in.
Medicare Advantage.
Oh, I meant to
someone
do that
should be
before I
muting your
left. I'm
phone,
sorry.
please.
Uh-huh.
We can hear you. We can hear
Want me to
you.
come down? Okay, I'm coming right down. I finished.
All major Medicare Advantage organizations were included, except for Johns Hopkins and Alterwood Advantage. Alterwood Advantage is a relatively new payer to the APCD and began submitting data in 2024 for 2023. I'll also note that the percent of members with Medicaid by zip code includes all Medicaid enrollees divided by the total population, including commercial, Medicare Advantage, Medicare fee-for-service, and Medicaid for that given zip code.
All right, Joe, I'm going to interrupt you for a second. Can we advance the slide, please? I think you're on the caveat slide.
Yes, thank you. And now if we could advance to the key findings slide, please.
Sorry, one quick question of clarification. Did you analyze claims from Medicaid as well as the private payers, Medicare Advantage, Medicare fee-for-service? And first statement on the caveats page.
So this analysis includes data from private payers, Medicare Advantage, and Medicare fee-for-service. It does not include Medicaid data.
we'll fill you in on that.
Looking forward to it.
All right, let's go to our key findings. So first key finding was that overall spending remained consistent across the period. So primary care spending ranged from an average of 3% of total medical expense for Medicare fee-for-service members to 6.1% of total medical expense for commercial members. Across payer types, primary care spending was pretty flat as a percent of total spending. However, it declined slightly on a per member per month basis. And we'll talk more about that and show you some more data on that in just a minute. There was minimal variation across commercial payers. So primary care spending was generally consistent across Maryland's commercial payers, with all but one spending between 6% and 6.3% of total medical expense on primary care in 2023. Across commercial payers, primary care spending equaled about $20 per member per month during that same period of 2023. We did see more variation across Maryland counties. So commercial primary care spending as a percent of total spending varied by county in 2023, ranging from approximately 4.1% in Allegheny County to about 7.1% in Calvert, Frederick, St. Mary's, and Wicomico counties. In 20,
I hate that, and I'm sorry, as we go into this, when we're talking about counties, are you counting, when you say spend on primary care and accounting, are you counting spend meaning the resident is a resident in that county and all healthcare is attributed to that resident no matter where they get it? Or are you counting the provider is located in that county and therefore medical services by the provider are provided? You see what I'm saying? Like,
yes, it's
if
on
I go to Baltimore County, I live in Howard County, is that a spend for Howard County primary care because I'm a Howard County resident, or is that a Baltimore County spend because the doctor's in Baltimore County?
it's a resident-based analysis.
Okay. Thank you. That's
Sure. In 2024, MHC's focus was on measuring progress towards investments in primary care spending. And so we'll also share with you a few recommendations later on in the presentation. Let's go to the next slide. Thank you. So as you can see here, and as I mentioned on the previous slide, spending was pretty flat on a percent spend basis. We'll show you those per member per month amounts in just a minute, but overall, on a per member per month basis, spending did decline just a little bit. One of the things I wanted to note is, in most other states, we see steeper increases in total spending. And as a result, the per member per month amounts sort of struggle to keep up on a percent spend basis. So this was a little bit different to see sort of a steady percentage as a percent of total medical spending, but to see the actual dollar spent on a per member per month basis decline slightly. Note that in Medicare fee-for-service, we actually saw an increase in both, where you see there a slight increase on a percent of total spending basis, as shown here on the slide. On a per member per month basis, the amount increased from about $23 PMPM to about $28 PMPM. All right, let's go to the next slide, please. And I think there may have moved 2 instead of 1. You could go back 1 slide. Thank you. Here we want to show differences by payer type. So as you'll see here, the amount paid on a per member per month basis for commercial is less than on a per member per month basis for Medicare Advantage and for Medicare fee-for-service. However, on a percent spend basis, the amount paid for commercial is more. And this is consistent with what we see in other states, where essentially those Medicare and Medicare Advantage beneficiaries have higher total spending. And so primary care is a smaller percentage of that total spending. All right, now let's go to that next slide. Thank you. As I mentioned in our key findings, you'll see here that most of the commercial payers had almost identical spending on a per member per month basis, between $17 and $20 per member per month. There was one outlier there on a percent basis, and that was driven by lower total spend, not the difference in what was spent on a per member per month basis on primary care. I want to note that we typically don't see payers with such consistent spending across each other, so this was an interesting finding for Maryland. I also want to note that this is based on fee-for-service only payments, and so we did not include in this analysis non-fee-for-service payment. If you go to the next slide, here we'll see a mapped depiction of percent spend by county. And again, this is also a resident-based analysis, so the dollars would roll up to where the resident lived rather than where the care was provided. On the next slide, we have a little bit different view, but also based on geography. So here you'll see variation across the regions. Variation was pretty minimal among the commercial primary care spend across regions on both a per member per month basis and a percent spend basis. So on a percent spend basis, varying from about 5.9% in Baltimore to about 6.5% in the DC metro area. And then you see almost identical per member per month spending, ranging only a couple of dollars across the different regions. You go to the next slide, we'll show you a similar table, but here it's on a Medicare Advantage. And you'll see there's a little bit more variation on the Medicare Advantage side. So ranging from about $30 PMPM or 3.2% of spend for Baltimore Metro to $44 and a little bit over 4% of spend for Western Maryland. The next slide shows us the same table, but for Medicare fee-for-service. And here, similar to the commercial, relatively minimal variation in spend, although just a bit more on the PMPM side, with per member per month amounts ranging from as low as $27 in Baltimore and Eastern Southern Maryland, up to $32 for DC Metro. Next, we wanted to share with you some draft report recommendations. So if you go to the next slide, and then forward one more, please, to the report recommendations. If we could forward one more to the report recommendations, thank you. So the first recommendation is to require payers to annually report detailed information on primary care investments via the alternative payment model data submission to assess the impact on health equity, quality, and cost resulting from increased investments in primary care. So this would essentially begin to include those non-fee-for-service payments as part of measurement. This enables the utilization of a comprehensive reporting structure to assess primary care investments in dollars and as a percentage of spend, integrating both claims and non-claims data or fee-for-service and non-fee-for-service payments to evaluate the collective impact on access, cost, quality, and equity. The next recommendation is to develop strategies for harmonizing the use of data to measure investment effectiveness on quality. This would establish data use guidelines to supplement payers' internal analyses to support all payers in developing effective investment strategies. Next slide, please. The next recommendation is to enact legislation that requires payers to increase investment in primary care as a percentage of total medical spending to meet annual minimum thresholds in line with the recommendations of the 2024 Primary Care Investment Analysis and Recommendations Report. This legislation should be introduced after the state has agreed on the definition of primary care and signed the AHEAD Model Participation Agreement with the federal government, and implementation is underway. Investments would be aimed at primary care providers who participate in value-based care initiatives or have achieved recognition from the National Committee for Quality Assurance as patient-centered medical homes. The Advancing All-Payer Health Equity Approaches and Development Model, also known as the AHEAD model, will require Maryland to meet primary care investment targets for Medicare, Medicaid, and the commercial market. Setting targets in Maryland law is appropriate given the AHEAD model requirements. Next, I'll turn it back over to Melanie to discuss next steps.
Thank you, Mary Jo, and she will be online to answer questions after we're done with the presentation. So,
of course, yes.
Next slide, please. So what are our next steps? So we plan to continue to support the payers in identifying methods to boost investment in primary care and assessing the outcomes of those investments. This effort will involve integrating primary care investment measurement and aligning the payer models with the AHEAD, as Mary Jo mentioned. We plan to engage stakeholders in discussions on refining primary care investment goals and determining how these funds should be allocated among the primary care providers, and to further explore effective approaches for recognizing non-claims payments for primary care services. Next slide, please. So staff requests that the Commission approve the release of the 2024 Primary Care Investment Analysis and Recommendations Report as required by Chapter 667, Maryland Healthcare Commission Primary Care Report and Work Group. So next slide, please. So that's the end of our presentation. We thank you for allowing us to present an overview of the 2024 report, and Mary Jo and I are happy to answer any questions anyone may have.
Thank you.
This is a report. We will
Have your hand up. Go ahead. We'll discuss it first.
Thank you for the report. I love the work as a primary care doctor. It's great to see people paying attention to how we can enhance primary care services to all Marylanders. The one specific question I have, slide 17, you talk about enact legislation that requires primary care investment. Is that necessary? I thought we already did that we set funding targets for every year to get up to 11%. So that's the question I have.
So that was not legislation. That was just a recommendation that we put into the report. The legislation would require the payers to meet those goals.
So is this going to, so we're going to submit this report to whom after this?
This will go to the Oversight Committee, Senate Finance, the Health and Government Operations Committee. So just to put a finer point on what Melanie said. So the recommendation in last year's report was voluntary targets. We didn't see that much change from 22 to 23. And oftentimes 1 year is not enough to see change, especially because we were into 23 when the recommendation came out. So elevating it was kind of hard when you had 3 months to show improvement. But I think there was a feeling that given the AHEAD model, it would be appropriate to establish targets formally, because that's going to be a key element of AHEAD. Here's the hitch, is that the definition of primary care that was developed by the Primary Care Investment Work Group, which we call the multi-state definition, because it's consistently across probably almost a dozen states, does not align with what the CMMI team has come up with. Their definition is broader and includes standalone behavioral health services, as well as obstetric, certain services provided by OBGYNs. The multi-state model does in certain circumstances include integrated behavioral health services provided, as you know, Dr. Basinski, within the framework of a primary care practice, but it doesn't include, Ben Steffens, psychologist, who's thrown open his shingle and is seeing patients as ID appropriate. So that's a pretty big difference. And what it means is that the AHEAD model definition of primary care yields about a 1.5% higher primary care share than the multi-state definition. In discussions with the department, we feel as though it's probably better to get alignment among all stakeholders. Are we going to use there are strong reasons for using the CMMI definition. We are in the AHEAD model in some way or another. I think it will be a factor, but we also want to compare ourselves to more than a dozen states that have similar models. So we're trying to work that out. And I know you had a question or a precursor to a question, a look on your face, where's Medicaid? And that is that Medicaid is working on yet a third definition. The MCOs, argue, well, we already have primary care medical homes required under Medicare, the Medicare program. Let's use that. By that calculation, they would be already well in compliance with the CMMI, the AHEAD model definition. We would be doing fine. So we didn't use AHEAD. We didn't apply any definition to Medicaid because there's not consensus between Medicaid, the Medicaid MCOs, and really the primary care investment work group on what definition included. But the bigger debate, I think, is between these two definitions. In some ways, I feel let's just agree on a definition and move forward. Obviously, if we go ahead with the AHEAD definition, the target would be different than if we use the multi-state definition, which is about, as I said a minute ago, about 1.5% lower because of the fact that AHEAD uses OBGYN services and standalone behavioral health as primary care. I think both are very important, but I think most primary care providers would argue that they are not behavioral health providers per se, and we'll have to work that out. Did I miss anything, Melanie?
No, I think you summed it up nicely.
If one of those two definitions was applied to Medicaid, where would their spend be? Does anybody?
So what the definition that was used by Medicaid, the spend is well ahead of what CMS has established as a conceivable target, which I think we found that based on the definition that the MCOs want to use, it's about 10%. Is that correct?
Yeah.
Which would be, well within the comfort zone of what CMS says they want to see in Medicaid. I would like to see us align across all payers types on one definition, but different payers have different perspectives on this. The leadership wants to try to build consensus. The other question I just wanted to elaborate on is that we talked about the primary care contracts. We include primary care contracts that include an element of risk or some precursor to risk. So things like the largest primary care program in the state, the Care First MD, PCMH program, we don't count that. That's why the numbers that are engaged in these advanced primary care programs are such low numbers, because the biggest program we're not actually counting because it doesn't have a value-based payment that is shared savings or risk. The payments are delivered currently through the fee-for-service structure, so it doesn't get counted. But it's certainly a very big advanced primary care program by other measure yardsticks of primary care.
Thank you, appreciate that.
An obvious question. It requires payers to increase investment in primary care as a percentage of total medical spending, which is a great thing, but where's it gonna come from? And
Yes,
You mean where does the money?
where does the money come from and
Comes from you when you get your
where's,
insurance.
yeah, so premiums are going up. Or some areas are getting less money. I mean,
So,
has there been any thought?
so I
to-
mean, I think
I'm just curious.
the concept of setting a spending target, and it's not without a flaw or two, is that this would come through offsets, savings in other parts of healthcare delivery, less specialty care, less inpatient utilization, better drug management. All of those would lead to savings if primary care is more effectively used. I think there's, for those of us who are stalwarts and believe this is working, we find enough evidence that it's true. There are some, skeptics that say, I'm worried about that. I don't see that coming. And I think, over time, those that are convinced have grown in numbers. Skeptics, there are still skeptics, but they remain. What I will say, is I think a bigger question of setting targets. Is that wise? We're going down that pathway, carving up the healthcare budget in, 10%, 7% for primary care. Does that lead to, we should spend, 7% for behavioral health services? Maybe. Well, we talked about cardiac care. I'm going to go and maybe Eileen has an idea about what percentage should be. We carve up the budget, it kind of takes away the role of the payers and the providers in this entire calculation. I worry about this of going too far, but I still believe that given the underuse of the primary care services, that it probably makes the most sense there to set some targets. I don't know how hard they have to be, but I think setting some goals makes some sense to me, given the historic underfunding of that particular category of service.
So the thing I'm concerned about is not that enhancing primary care won't reduce medical costs. It's that enhancing primary care today will reduce medical costs in the future. So I don't think next year doubling the amount of expenditure on primary care is going to cause anyone not to have cancer in that year, or not to need a heart surgery in that year. So there is a mismatch in the timing that in the short term, then it seems to me is likely to increase costs. I'm not an expert, I'm just a lawyer, so.
You know what? I think you're 100% right. It will not be in the same year, and it might not be for 5 years or 10 years, but I believe if you look at kind of literature, how there could be exponentially decreased costs in 10 years, right? Because if you catch things, so in primary care, all the prevention work happens. And if people really go and there's things that are caught early, then you don't have to have all that really expensive stuff in the future. And so in my opinion, we're thinking about compensation, et cetera. In my opinion, primary care has increasing quality measures to hit in order to improve the health status of communities and reduce spending in the future. And I think their compensation needs to be also looked at, because I don't think it's enough. I think that if America is going to really change the health status of America, it's going to happen in primary care, and all those specialty things where the real money is being spent theoretically should go down, down, down if we manage things well through population health. That could be done through primary care. So I think they need more money too. Just saying.
Okay. So My understanding of the recommendation is we're recommending legislation in support of what's negotiated with CMS and HED.
Yes, I think we're in some ways saying, there should be a target for primary care. We need to work together with CMS, and stakeholders to come up with what the target is, or maybe more specifically, what the definition is of primary care. Because it makes no sense just to an abstract set a target and then decide later what's going to be included.
And we really haven't, there was Colorado, but we really haven't had experience over time with the jurisdiction that set a target like this and measured the results.
You want to comment on that? Ms. Condon, that probably you know more about what other states have done. I will concede that, the voluntary targets seem like a good idea. That's like what, I oftentimes got when I asked what my kids wanted dogs, they would always promise to walk the dog. We got from the payers, last year, that they definitely thought this was a good idea, and voluntary targets sounded perfect. But I am somewhat skeptical. Mary Jo, do you have anything to add?
Sure. So there's a few states that have primary care investment requirements, and then a few more that have targets. And so the difference between those sort of being the degree to which the state has an enforcement mechanism. So the first primary care investment requirement was put into place actually by Rhode Island more than a decade ago. And that aimed to initially increase primary care spend there about 1% per year, 1 percentage point. So from 6% of total spend to 7%, et cetera. And they did that for a few years, and then they put in just sort of a defined target of 12%. And so that's been in place for some time now, and has been successful in reallocating dollars to primary care.
Oh.
And so separately,
Okay. Is that why you said take your call?
we also
I mean, is that
have-
why you did? I don't really care if I can get off. All I'm
No,
doing now is
excuse us,
trying
you're
to
on-
hold out for
the
my
person
person to
talking is on.
present, but.
You're not gonna hear it.
Teresa, you're on the call.
Hold on, Mary Jo.
Sure.
We know who you are. We're going to shut you off.
Lisa Lee's on.
All right, I think you can try.
All right, no problem. So Rhode Island has had that requirement in place for some time. It's been pretty successful. Some of the things I think is really interesting about how primary care is delivered in Rhode Island, things like integrated behavioral health and broad team-based care, including pharmacists and other clinicians, is pretty common. And is facilitated really across practices through shared learning. And a lot of that is the result of that increased investment that they've seen, but it has taken time to get everything in place. They do also have what I think of as a defined offset. And so they have a cap on hospital price growth. Other states with a requirement include Oregon. Its requirement just went into place last year. Last year was also the first year of enforcement for the requirement in Delaware. So those are newer, still sort of seeing how that plays out, but both of those states are reporting increases in primary care investment. The last state with a current requirement in place is Colorado. It has not had perhaps quite the same level of enforcement, and primary care spending there has remained pretty flat. As a percent of medical spend, they sort of have shifted their focus to value-based payment.
So
go ahead.
I guess my question, because I don't want to, maybe we don't know, that I fully believe that we can implement a target and the state can enforce it and we will achieve it. But that seems to be your definition of success. And what I want to know is, are the people healthier 10 years later? Are they paying
Sure.
less for healthcare than they were 10 years later? That's the thing. I don't know. Do we know that from any of these experiments?
Sure. So we do have work that was done by the Robert Graham Center that looked across states and saw that states that had higher primary care investment had lower rates of hospitalizations, lower rates of avoidable ED use, lower rates of avoidable hospitalizations. We recently conducted an analysis using the Massachusetts APCD that found that medical groups with higher primary care investment had no increase in total medical expense, but did have better quality and did have lower cost in terms of hospital care, both inpatient and outpatient. A similar analysis was conducted in California. So I think there is research that shows that higher primary care investment tends to result in better quality scores, lower spending on hospital services. And over time, there's some evidence to suggest lower total spending overall, although a lot of it is sort of a shift, right, in sort of moving the healthcare dollar from hospital services to primary care. Does that better answer your question?
It sort of does, but when you mandate a spend, it's not necessarily spent on the exact same thing as when you just say spend a primary care spend in the abstract. So if you say you must, like, there are second order effects, you must spend 11% on primary care. Envision a world like where you balkanized it the way Ben didn't suggest, but like the horrible world where now everybody's got a slice of that dollar, and you get to the end of the year, you can see what happens, right? It's like somebody's trying to, like, we've got to come up in this category, we've got to increase the money here, we've got to come up in that category, increase the money there. It doesn't mean that it's spent equally wisely. So what I was really asking about was, do we have impact that a mandate of a certain spend is increasing overall healthcare? Or is there a second order effect that I should be worried about? You mentioned one in Rhode Island, they mandated it, and they also capped hospital rates. Like, there's another way to get to that 11%, right? Like, not just spend more money, it's take money from someone else.
That's the point I was trying to get.
Yeah, so. And maybe we don't know, like that. I may be asking a question that is not susceptible to proof.
I think what I can tell you is, one, that in states that have higher primary care spending, we see less use of unnecessary hospital services, including ED visits, avoidable inpatient admissions, and higher quality of care. In states where there is not increased spending, we don't see that. And in states that have a aspirational target but no enforcement, we see no increased spending. So for example, if you look at Connecticut, which has a target but no mechanism by which to compel payers to spend more, they've actually seen a decrease in primary care spending as a percent of total spend, because total spend has been going up at such a higher clip. So there's, we don't have an analysis of sort of looking at Rhode Island, which I think is the only state that's been doing this long enough to really get that longitudinal view and say that their costs are lower as a direct result of that increased investment. But I can tell you that primary care looks different there, and that those differences, I think, are palpable both to clinicians and also to the patients that they serve.
Thank you.
Yeah, I was just gonna say that since Connecticut is also joining Maryland, Vermont, and Hawaii in the AHEAD model, they too will have to face the same dilemma that we're working with, which is what is their primary care definition, and how will that goal be incorporated in the law. So they're marching down the road with Maryland on the AHEAD model.
Thank you. Are there any other questions or comments? If not, I'll call for a motion to approve the primary care investment analysis and recommendations report.
So moved.
Mr. Jensen, thank you. A second?
Second.
Mr. Brzezinski. All in favor?
Aye.
Aye. Any opposed? Oh, good. Motion passes. I was a little quick on the any opposed there. We didn't cut off anybody's eye. Congratulations. That was a lot. We made it through the action items. We have some presentations. Also have this one, right? Yeah.
Do you know?
Now, I guess, man, as we get further along, something you want to talk about, whether there's anything we should move to the next one.
Yeah, I mean, I think it's up to you and the other commissioners if we want to defer this. Or, we have two more presentations, probably another half hour. Conservatively. Or if we want, if the commission wants to hear both of these presentations. We move them to November. November's agenda looks pretty, we're getting ready. So just saying.
My suggestion is we do this one at least, and then we can talk about like how long that one takes.
Mine is relatively short. That helps.
6 months or less.
Yeah, exactly. I was gonna
Thank
say.
you, thank you.
All right. The Maryland Healthcare Commission collects data through administration of an annual hospice survey for all licensed hospice. Again, I thought it was a prison joke, but again.
We get it.
All licensed hospices in the state. The purpose of this survey is to better understand the needs of our residents, monitor changes, use rates over time. Daisy House, the Chief of Long-Term Care and Health Plan Quality Initiatives in the Center for Quality Measurement and Reporting, will present our most recent survey results with an emphasis on racial trends in hospice use. Daisy, please proceed.
Thank you. Good afternoon. Next slide, please. So the hospice survey is administered yearly to all licensed hospices, and it's required to be filled out by all hospices. They have to supply information about all of the patients that they serve each year. It's administered by the Center for Healthcare Facilities Planning and Development, and then the data is analyzed by the Center for Quality Measurement and Reporting. The sources that I used for this analysis were the fiscal year hospice surveys 2014 through 2022. We also used the CMS Hospice Standard Analytic File and the CMS Master Beneficiary Summary File. Next slide, please. Okay, so here we have the hospice use rates for the past several years. For 2020 and before, the use rates were calculated by dividing the total hospice deaths in Maryland by the total deaths in Maryland, but only for those that were ages 35 and older. And last year we held a work group with the hospice industry. One of the results of that work group is that we agreed to also begin calculating the hospice use rates the way the majority of the hospice industry calculates hospice use rates. And that's by dividing Medicare hospice deaths by total Medicare deaths. And so now the calculations are different for 2021 and 2022. And so now you can see that our use rates have been lower than the national rates, but now they are much closer to the national rates, still a little bit lower, but much closer. Next slide, please. This slide gives you an idea of what the hospice use rates are in each county across the entire state of Maryland. This slide does not change very much year to year. The lowest rates typically are in Allegheny, Prince George's, and Somerset. And the highest rates typically are in Baltimore County, Harford, and Carroll. Next slide, please. This slide is the exact same information that was on the previous slide, but I have it grouped by region of the state. I just wanted to show you that there's no real discernible pattern by region of the state. There are counties that have low use rates and counties that have high use rates within each region. Even the National Capital Region, which only has 2 counties in that region, it has Prince George's County, which has the second to lowest hospice use rate in the entire state, but it also has Montgomery County, which has a use rate that is very close to the state average. Next slide, please. This slide gives you an idea of where people are receiving their hospice services. Typically, the most common location to receive hospice services is in the private home. But other popular places to receive hospice services are in inpatient units, skilled nursing facilities, and assisted living facilities. Next slide, please. Patients are sometimes discharged from hospice for reasons other than death.
And the most common reason for being discharged in all regions of the state, with the exception of the Eastern Shore, is they are discharged by the hospice. And that includes patients that are not recertified for hospice because they're no longer terminally ill. They move out of the service area but don't transfer to another hospice, or they're discharged for cause. The second most.
Discharge for cause.
Yes.
Cause, what would be a cause to discharge somebody?
They're not compliant with their plan of care, or they become a problem of some sort. That can encompass a lot of things.
Okay.
And the second most common reason in all regions, and the most common region in the Eastern Shore, is a patient's withdrawal, which includes people who revoke the Medicare hospice benefit, or they desire treatment that's inconsistent with the hospice plan of care. Next slide, please. This slide gives you an idea of the primary diagnoses at admission. And the three most common diagnoses are all cancers, heart disease, and nervous system diseases. Those are the top three diagnoses, and those have been the top three diagnoses for at least the past 3 years, in that order.
What would we treat dementia on this list?
What would be what?
Where would dementia fall into this list?
Dementia would fall under mental, behavioral, and neurological.
Seems relative, this seems low.
And then skin diseases is the least common, and it has been the least common for at least the past 3 years. Next slide, please. So this slide gives you an idea of hospice use over time by race. The blue line is hospice, is Marylanders who identify as white. And you can see that that's a fairly steady decline over time. And then the red line is Marylanders who identify as Black or African American. That line has been relatively steady over time, with a small dip in 2021 and a very small increase in 2022. It'll be interesting to see if that changes anymore over time when we have more data. And then the aqua line is Marylanders who identify as Asian. That line has been relatively steady over time. The interesting line is the black line, which is Marylanders who identify as multiracial or other. That line has gone up rather dramatically over time. So that line actually makes the red and the blue line difficult to interpret. So we don't know if this just reflects the changing demographics of Maryland, or if there's no ability to refuse to answer this question. So we don't know if it's just the changing demographics of Maryland, or if there's an increased reluctance to report race on the by hospice patients, or if there's an increased reluctance to ask about race on behalf of the hospice workers. Maybe there's a fourth or fifth thing that we're not thinking of. Maybe it's a combination of all these things, but it's something to keep in mind when we talk about race and hospice use. Next slide.
These columns out up to 100, they really don't have anything to do with the broader demographics of the state. This is just out of 100 people who died. So many are white, so many are African American, so many are.
Yes, next slide, please. So the commission has been committed to outreach to the African American population when it comes to health equity in general, as we all know, but hospice has been a particular target of outreach over the years. So for example, in 2013 to 2015, the commission conducted education and outreach to increase the use of hospice in minority populations, with a particular emphasis on African American populations in the state. And in 2016, CON opened applications for PG County and Baltimore City with the hopes of opening more beds in hospice. And in 2020 to 2022, the Center for Quality Measurement and Reporting developed multiple hospice brochures, infographics, and presentations to increase awareness of the Medicare hospice benefit and to decrease the existence of hospice myths. And our center has talked to you about the presentations and brochures that we have given to county librarians, senior centers, hospital discharge planners over the years. And we have a big presence on social media and we attend multiple expos. As a matter of fact, we're going to the Power of Age Expo in 2 weeks. And so we spend a lot of time trying to make sure that people know about the Medicare hospice benefit and people know what hospice is and what's available to them so that they can make the best decisions for themselves. Next slide, please. So a little bit more about hospice use and race. This slide tells you what the hospice use rates look like compared to the actual populations in Maryland, so you can get an idea of proportion. So the African American and Black population representation in hospice use and Asian hospice use and Hispanic hospice use, you can see that they are underrepresented in hospice use compared to their population, to the population in the state of Maryland, while those who identify as white are overrepresented in hospice use. Interestingly, the only racial category that seems to be relatively well represented is the multiracial or other category. Next slide, please. So this slide shows you hospice use race and region. And the National Capital Region and the Northwest region are basically the only regions where races are proportionally represented in hospice use. The other 3 regions, the numbers are fairly skewed. Next slide, please. This slide is African American Marylanders only. So this is hospice use by African Americans by region over time. I wanted to show you African American or Black Marylanders and how hospice use has changed or has not changed over time when it comes to hospice use. So if you look at the Baltimore metro area and the Eastern Shore, the numbers have remained relatively steady when it comes to hospice use. But the numbers are not proportional to the populations in those areas. And then when you look at the National Capital Region, the numbers have jumped around a bit over the years, but it's more proportional to the area. Northwest region, those numbers have remained pretty rock solid, but it's pretty proportional to the area. The Southern region is the most interesting, I think. Even though the numbers are not proportional to the area, they seem to be on the rise. So those numbers appear to be changing, and I think that area will be pretty interesting to watch over time. They seem to be increasing. Next slide, please. So in conclusion, the hospice use rates, they're a little lower than, but comparable to the national rate. They've remained a little lower than desired across the state. They appear to be declining for whites, a little bit for African Americans, but there was that very slight increase in 2022, but we have to see what happens in the next few years to see if it actually means anything. As I mentioned, that increase in other and multiracial makes the changes in white and African American Marylanders a little difficult to interpret. So we need to pay attention to that. And additional outreach might be needed in certain areas. Might be needed in some areas of the state to make sure that all Marylanders know what is available to them when it comes to healthcare. And MHCC is, as always, committed to health equity and making sure that everyone has access to all of the information they need to make sure that they can make educated healthcare decisions, especially when it comes to hospice and what is available to them.
Thank you. Are there any questions? Looking at the patients by race, it occurs to me, it seems like to make sense of this in terms of what any individual person's experience of any particular race is, you're gonna need to age adjust these numbers. Like, you can look at this and go, I see the white population is the oldest and the Hispanic population is incredibly young. That would actually turn out to be correct. Like, the people going into hospice, if they're generally old. Like, I'm not sure that without age adjusting the numbers, that it reflects a particular population's use of hospice, because the people going into hospice are just a bigger percent of the population. So it's a complicated calculation, but I think it needs to account for it. those. So it's like, you can see a particular on the Hispanic, where it's 2%. In hospice, 10% of the population, but if you look at the average age of the Hispanic population, it's far below the average age of the white population.
Interesting.
And you also said looking at the trends for southern area, with their changing of hospice in general. So now they are owned by the Charles County and the Calvert have combined with the Anne Arundel County, Chesapeake. So I think that probably has a lot to do with the rise and the change because, you know, Charles and Calvert at some point were almost about to close. So people were hesitant to even consider utilization. So I think that's where a big change is going to start happening.
That's a really good point.
Thank you. Any other questions or comments? Thank you very much. Okay, if we can get one more in. Item number 9, Maryland's privately insured weight loss medications cost and utilization, 2021 to 2022. Weight control has been a hot topic in the past decades. The glucagon-like peptide 1, GLP-1 drugs, are a new class of therapies, and there's hope that they may dent obesity rates and interlinked chronic diseases. Considering extensive marketing efforts promoting the benefits of Saxenda, Wegovy, Mounjaro, and Zepbound in managing obesity and its related health issues since 2021, MHCC conducted a study to describe the distribution of weight management drugs in the APCD and showed the changes of cost and utilization of these drugs from 2021 to 2023. This analysis utilized data from the Maryland Medical Care Database. The MCDB contains health insurance enrollment and healthcare claims data for Maryland residents, offering a comprehensive view of spending and utilization trends for gender affirmation services. People in the wrong. Okay. Shankar Mehta, Chief of Cost and Analysis at the Center of Analysis and Information Systems, will update us on this report.
Thank you, Mr. Chairman, for the introduction. Before coming here, I was thinking that this presentation will take minimum of 14 to 15 minutes, just my presentation and followed by questions. But given the crunch of time, I'm going to try my best to make it into as concise as possible. Next slide, please. As many of you know, that 40% of US adults are affected by obesity, and the recent data from National Health and Nutrition Examination Survey have shown that while the age-adjusted prevalence of obesity in adults has remained stable from 2017 to 2023, but the prevalence of severe obesity, which is BMI of greater than 40, has increased from 7.7% to 9.7%. And additionally, over 70% of US adults are classified as overweight, which drives the message of the scale of the health concern. And when we look at obesity prevalence by region, we find that 34.2% of adults in Maryland have BMI of 30 or higher, and with county rates varying from 25% to 47%. In comparison, prevalence of obesity is lower in District of Columbia, about the same in Virginia, and higher in Delaware and West Virginia. So it is very crucial for us to understand the economic implication of obesity, and the annual medical care cost rise by about $3,508 per obese individual. And this relationship is kind of a J-shaped, meaning that the cost increases exponentially in the category of class 2 and class 3 obesities. And as Mr. Chairman introduced, the emergence of glucagon-like peptide drugs offers hope in combating obesity-associated diseases. However, they come with a significant cost, with a sticker price of more than $1,000 a month and a potential requirement for lifelong use. Next slide, please. So what do we know about the access so far? So it's very important to recognize the crucial role that the health insurance payers can play in lessening the patient's financial burden. Historically, older weight loss medications have demonstrated limited effectiveness and significant side effects, prompting numerous public and commercial payers to exclude them from their coverage. And regarding the employer coverage for weight loss drugs, the recent data from the pharmacy benefit managers indicate that the coverage in the employer plans ranges from a minimum of 33% to 63%. And additionally, the use of prior authorization requirements among employers that cover weight loss medications ranges from 50% to 80% across the different pharmacy benefit managers. When we look into the public payers, the Medicare Prescription Drug Improvement and Modernization Act of 2003 excludes the obesity and the weight loss medications from coverage in Part B and Part D. However, the medications which are indicated for diabetes, such as Ozempic, Victoza, and Mounjaro, are required to be covered at a class level for the treatment of diabetes under Medicare Part D. Moreover, Medicaid coverage for GLP products typically require prior authorization, especially when it's used for the treatment of diabetes. Next slide, please. Yeah, now the fun part of using APCD. So for this analysis, we really had to really go through the environmental scan, because it was very tough challenge personally for me to come up with these 4 drug medications, because when we look into the GLP as a class, there are so many different medications in the group, and they have a more than one use, which is mainly for type 2 diabetes, and then the recent usage of weight management. So we had to really come up with this shortlist, these 4 medications, and among these 4 medications, I mean, most of the information is there in the on the slide, so I'm not going to go into the detail, but I just want to mention that among these 4 drugs, the first one, Saxenda, is used exclusively for weight management. Wegovy is also used exclusively for weight management. The last 2, the Mounjaro and Zepbound, they have a mixed use of either they can be given for the type 2 diabetes or the weight management. So what it means is, in our analysis, when we try to get all our patient sample size or the prescription count or the cost or the patient population, what we see for Mounjaro and Zepbound, it's very, very hard to separate that if those were exclusively given for the weight management or it was given for type 2 diabetes. Next slide, please. So this slide basically looks at it from a very high level of what is the availability of the patients who have been prescribed these medications, and what are their prescriptions and what are the costs associated. And what we observed is that all these 4 medications showed varying patient utilization patterns, prescription numbers, the total paid amounts, and the out-of-pocket expenses over the years. I mean, I don't want to go into the detail of each medications, but the theme is consistent across. The utilization is going up, the cost is going up. The only thing that stands out is the first drug, the Saxenda, where we are seeing the prescription is going down for 2023, indicating that there is a competition from these newer drugs in the market. Next slide, please. Yeah, in this slide, we try to look at the cost and utilization from the standardized metric, which is the per member per month and the per patient per utilization. The one drive home message in this slide is that when we look at the difference between how this drug is for the entire population, which is per member per month for the entire population, we see that it's really not that, it is not really denting that much to the payers. But when we look closely, we see that for Mounjaro and for Wegovy and Mounjaro, in the initial year, the per member per month cost is less, but in the next year, it really goes up very high, which indicates that this medication is causing that impact, the financial impact on the payers. And when we look into the patients who are using these medications, the data is showing that these medications are very costly and can really cause a financial stress on the patients who are using if there is no support from the payers or other arrangements. Next slide, please. And this slide basically tries to look into from what is the cost from just the out-of-pocket perspective. And again, the message is same, which is when we try to generalize this out-of-pocket cost for the entire population, it is really not that big. But when we try to focus on only the users or the patients who have been using these medications, the cost per month is higher. Next slide, please. All right, so this is my final slide. So what is the takeaway message? The takeaway message is that in Maryland, the data shows that we have about 34% of the adults who are in the category of obese. And we see that the neighboring states, District of Columbia, Washington, DC, and Virginia is about the same. And it is more higher in Delaware and in West Virginia. The last one is, yeah, so what does this tell us? That considering all the choices available to the patients, providers, and payers, so it is very important to recognize the dilemma of choosing between the costly and effective GLP-1 medications for chronic conditions, or to continue to use the less effective older drugs with behavioral coaching. While combining the GLP agonist with lifestyle changes may provide greater benefits, but it will not solve the long-term challenges of the cost, the patient adherence, and the structural inequities in lifestyle counseling. That concludes my presentation. I know it was a very fast run through, but I'll open for questions.
Thank you. Are there any questions? I was struck on your second to last slide that the two most commonly used of like doubled in price in the last 2 years.
Yeah.
So not only with Labor, but for each one, you're paying the pharmaceutical company twice as much as you would have 2 years ago.
Yeah.
That was something I noticed too. Do we know why?
They can.
Demand.
I mean, it makes it very hard at a state level to set policy. You can't directly impact drug prices that way.
Do we see any offset between like it stayed, although we don't know what the 22 cost is, but it looks like it's less than a third cost of Wegovy and Mounjaro. The amount is only, the PMPM is $142, which is roughly 25% of Wegovy.
You don't have a lot of market share yet.
Yeah, considering the data that we used for 2023, we cannot really comment on Zepbound because Zepbound hit the market at the fourth quarter of 2023. So the data what we have is only for the 3 months in the data that is available. So maybe the next year we will have a better data about this medication, how it is driving the per member per month cost.
You only have 130 prescriptions in 2023.
Yeah.
And I know that we did try to collaborate with the Prescription Drug Affordability Board. Did they have any comments for this particular study?
Yeah, so they did added the comment about making it more kind of how we can drive the message, talk more from what it means for the state of Maryland. So one of the recommendations that we got was if we can look this from the state employees versus the individual market, because MCDB has a complete data for these groups. So maybe that will give more information on what is happening for these two groups.
If you say you could get that information quick, if we waited here, could you go back to your office and generate it? No.
We can try.
Where'd you get the information on the cost of the drugs?
The cost of the drugs, which is in the tables of the drugs, it is all from the pharmacy claims in the APCD. Those are all calculated cost.
And the APCD contains reported payment amounts, so they're probably very close to accurate.
Yeah.
I know that the from the pharmacy's perspective. Well, okay. The cost of drugs. So this is what people paid for the drug.
Yeah, this is what the health insurance company has paid for that medication, for that prescription.
Okay, and it includes any rebates they might get from PPMs or anything else at the end of the year. That's factored in.
It doesn't include that.
Yeah.
Excellent.
I don't know.
Well, I know, that's what I'm getting at.
So it wouldn't be part of the claim. The carriers would put it in the rates as a sum, like they account for it at the end of, when they do the rates for the year, so that people get credit for it, but they're not in the claims database on a per drug.
So we kind of know what the price is.
Yeah, I think that's a good characterization. On drugs that are heavily rebated, we know less than kind of
Right.
the generic type drugs that have no incentive associated with them from the standpoint of them.
So this is perhaps directional. Hopefully. Okay.
For me, I would love to see us measure over 10 years. Are there reductions for those people who are on these meds? Are there reductions from other populations in whether it's heart disease, diabetes, amputations, heart surgery, go down the list, dialysis? Because it makes a difference if we just say, well, this year it's $1 zillion, which is still tough to, I don't know how to handle that. But it makes a difference if we can understand the savings down the road.
And that's the same comment we've had on a couple other reports we've had today, is you're gonna spend money today to save money tomorrow.
I mean, it's hard because everybody's fiscal budget is 1 year.
Right.
But the truth is that some things maybe need to be seen as investments for future years.
Yeah.
So we're never gonna know.
No, you just have to have a longer view, that's all.
We'll argue about whether Commissioner Bazinski's enhanced primary care improved health outcomes or whether we were all on Wegovy.
You might get on Wegovy because of his program. I mean, if you see your doctor, you might get medication that works for you.
Thank you. With that, commissioners, we have one last item. This is the overview of upcoming activities. Ben, which I invite you, but do not require you.
Yeah. So we do have a CON for an AMSURG center. We'll have some of Eileen's team back to present some more certificates of ongoing performance. And we'll also have a couple more reports. I told you I would get out the full roster of reports that are due between now and the legislative session in 25. But Nikki will be presenting on the prior authorization report that was mandated legislation passed in 24 session. And we'll also have some of our mandate studies. Jason and actuaries will be presenting two. One on genetic testing, which we had our three commissioners participate on, as well as calcium scoring, which is a test that's used to examine a blockage in coronary arteries in patients that don't show any obvious risk of heart attacks, but may have accelerated, may be at a higher risk. So definitely a variety of projects that are going to come up, and we'll be mindful of everyone's time as we present those findings.
Thank you. All right, agenda item 11. I get a motion to adjourn the meeting. Thank you, everyone. Have a good month. I appreciate the engagement today. It's good discussion. Good discussion.
That was good. Okay. Sounds right.
You.
Serious, sir.
I read the email.